Hello dear students, a very good afternoon to all of you. So here we are again with this image-based session from Pediatrics. So we will be covering all the important images and the related topics which have been asked in the previous year exams, as well as some newer images which are potential questions for your upcoming NEET PG as well as FMGE exams. So this session is going to be super useful to both NEET PG as well as the FMGE aspirants. And we will be focusing mainly on the images, and as it is a revision session, I would expect you to participate and answer questions and make it more of an interactive session. We will not be going into a lot of details and keep it crisp and revise effectively, right? So before we start, we must acknowledge that we are all very tensed. We are thinking what is going to happen in the upcoming exams, what will be our fate. But we all know that the best way to predict your future is to create it. And I'm sure all of you are putting in lots of hard work, sincerity, and all your efforts are definitely going to see you through. So on this note, hello to Sailesh, Shan, Nausheen, Suvarna, Avdesh, Prakhar, Tasmina, Damru, everyone. So hello to all of you. I hope I am audible clearly and you're able to see my screen. Yes, I am good, Megha, right? So I believe your preparation is going in full gear right now, and I'm sure you're in your third revision at least, right? And so here we come with this revision of pediatrics for you. So in this, in this video, in this session, I've tried to divide the topics of, the images of pediatrics into neonatology, general pediatrics and systemic pediatrics for a more systematic revision, right? So let us start with some important images from neonatology. Yes. So what you see here, so you can see that this is a neonate. Can someone guess the diagnosis? So before I discuss this image, so can someone guess the diagnosis here? So what you can see here is a neonate, of course. And if you notice closely, what you can see is, in this neonate, if this is the right side and this is the left side, you can see that the left upper limb and the left lower limb, the size is more as compared to right side, okay? So there is hemihypertrophy. Hemihypertrophy. Hemi means half. Hypertrophy means enlargement. So there is hemihypertrophy. What else do you see? So what we see here is a defect where, through the umbilical cord, there is a sac which is containing the intestine and other contents. So this is a omphalocele. So hemihypertrophy, omphalocele, and usually these babies are large for date. Large for date baby, what do you mean by a large for date baby? A baby whose birth weight is more than 90th percentile of expected according to the gestational age, okay, right? And these babies can have macroglossia, which you cannot see in this picture, but they can have macroglossia or large tongue. So what is the diagnosis? So I can see Mahalakshmi has given me the answer. Mohit, yes. Max, so yes, the correct answer is Beckwith-Widman syndrome. So our diagnosis here is Beckwith-Widman syndrome. So you can get a straightforward question to identify the syndrome, or you can get a case scenario with these clinical findings, or the question can go one step ahead and it can ask, there is an increased risk of which tumor in this condition. So in this condition, there is an increased risk of Wilms tumor. Increased risk of Wilms tumor is there in Beckwith-Widman syndrome, right? Okay. So we saw what is a large for date baby, we saw the features of Beckwith-Widman syndrome, we saw the hemihypertrophy, increased risk of Wilms tumor, right? Okay. Moving ahead. What do you see in this picture? Yes. So you can see that a baby's head is turned to one side, and that side upper limb and lower limb are extended, and the opposite side upper limb and lower limbs are flexed, right? So what do you see here? What is this phenomenon in infants known as? So this is very good, very good. Proud of you guys. Mohit, Suvarna, Max, Alia, Fuzz, Pratiksha, very good. So what we see here is the ATNR. So this is nothing but ATNR, a physiological phenomenon, which is, what is ATNR? Asymmetric tonic neck reflex. So it is one of the primitive neonatal reflexes. It is asymmetric tonic neck reflex. It appears at around 35 weeks of gestation and disappears by 3 to 5 months of postnatal age. So, this reflex is present at birth in a term neonate, right? But the brother of ATNR, that is symmetric tonic neck reflex, is not present at birth, okay? So, this ATNR is present at birth, right? And what will happen when this ATNR is going to disappear? So, when this ATNR disappears, that is when the baby learns to roll over. So, the baby turns from, prone to supine and supine to prone. So, only when the ATNR disappears, the baby learns to roll over, right? Okay. So, moving ahead, what do you see here? Yes, what do you see here? So, here you can see that the baby is held and both the upper limbs of the baby are, like that extended, and, the lower limbs are also moving. The baby appears to be crying. So, what phenomenon is being done? In fact, you can get a video based question also for this, right? With your online mode of examination, the examiners also have the liberty of giving a video to you. Very good. So, this is the Moro's reflex, okay? So, this is, I can see many of you answering. Azam, Saurav, Deepak, Shailesh, Megha, Pooja, Damru. So, a lot of you answering. So, this is Moro's reflex. So, Moro's reflex is also known as embrace equivalent, because it is as if, the baby is embracing someone, right? So, what happens in a complete Moro's reflex? There is symmetric. So, remember, complete Moro's reflex is always symmetric. So, there is symmetric abduction and extension of upper limbs and opening of hands, followed by flexion and adduction, right? Along with movement of the head, trunk and lower limbs and crying. So many things together make up a complete Moro's reflex, okay? So, because there are so many components of Moro's reflex, one fine day it cannot appear. So, it begins to appear at 28 weeks of gestation. So, it begins to appear at 28 weeks of gestation, appears completely by 37 weeks of gestation and disappears normally by 5 to 6 months of age. So, Minhazul confused it as parachute reflex. No beta. So, this is not parachute reflex. What happens in parachute reflex is you hold the baby in ventral suspension. That means you hold the baby like this, the face is facing below, the back is facing up, the limbs are hanging loose, and you suddenly lower the baby. So, baby will spread the upper limbs and lower limbs like that to avoid falling on face. So, that is the parachute reflex that comes at 8 to 9 months of age and persists throughout life. But this is when the baby is held, in a supine kind of fashion, okay. So, this is Moro's reflex. This is not parachute reflex, okay. So, yes, Megha is telling ulta baby will be parachute, that's right. So, normally we said that the Moro's reflex is always symmetric. Now, many a times in the question, you've got a question that what are the causes of asymmetric Moro's reflex? So, what are the causes of asymmetric Moro's reflex? When only one side, Moro's reflex is happening. So, what are the causes of asymmetric Moro's reflex is important. So, it can be, some nerve related causes or some bone related causes. So, nerve related causes can be like if Erb's palsy, very good, Shailesh, behind the camera, I like your name, Yashmin. So, Erb's palsy, right? Congenital hemiplegia. So, that side Moro's will not happen properly. Or if there is a fracture clavicle, or if there is a unilateral shoulder joint dislocation. Okay, shoulder joint dislocation. So, these are some of the conditions where you can get a asymmetric Moro's reflex, right. So, normally it is symmetric, we can get asymmetric Moro's reflex in these conditions, and normally the Moro's reflex is going to disappear by 5 to 6 months. If it persists beyond 6 months, it indicates cerebral damage, right, okay. So, moving ahead. So, what is being done in this image? So, somebody is stimulating the angle of mouth of the baby, and what will happen? The baby will turn the mouth to that side and open the mouth as if to breastfeed. So, what is being demonstrated in this? Very good. Again, Yamin, Mohit, Pratiksha, Vijay, Muffin, Rash. So, very good guys. So, it is rooting reflex. Okay, it is rooting reflex which helps the mother in breastfeeding the baby. Rooting reflex appears at around 32 weeks of gestation, starts disappearing by 1 month postnatal age, okay. making it the earliest primitive neonatal reflex to disappear. Okay, so this is the rooting reflex. What do you see here? So, in most of the babies, you will see that on the buttocks or on the lower back or back of the thigh, you can get some areas of bluish black discoloration. So, they are a normal phenomenon, nothing to worry. Very good again, Mohit, Alia, Suvarna, Prachi. So, these are nothing but Mongolian spots, right? Mongolian spots. So, Mongolian spots are usually present in the lower back, buttocks, back of the thigh, and they are due to the migration of the neural crest cells. It is a normal phenomenon. It is going to disappear in a few years. But, there is a condition where you can get excessive Mongolian spots. So, Mongolian spots coming up to the shoulder, okay? Excessive Mongolian spots you can get in Tay-Sachs disease. So, excessive Mongolian spots, exaggerated startle. So, excessive Mongolian spots, exaggerated startle, you can get in some of the lysosomal storage disorders, okay, like Tay-Sachs disease, GM1 gangliosidosis, okay. But Moro's, this Mongolian spots as such is a normal finding, okay. What is this? So, you can see again this is a neonate with some erythematous because red in color, erythematous maculopapular lesions mainly on the trunk, but can be there also on the extremities. So, this again is a normal phenomenon seen in neonates. What is it called? So, Sanhita, no, it's not Salmon patch. Salmon patch is capillary hemangioma. But these are some erythematous maculopapular rashes present mainly on the trunk. Yes. So, Prachi, Dhaval, Megha, Azam, Twinkle. So, this is erythema toxicum, also known as erythema toxicum neonatorum. So, the name is toxicum. It is a totally benign condition, does not need any treatment. It is due to some immune phenomenon, usually seen in the first week of life. It is going to be disappearing on its own. And these are, sterile lesions, no infection, nothing. These are sterile lesions and they are eosinophil filled sterile lesions. So, due to some immune phenomenon, right? But on the other hand, if a baby is having lots of pustules, more than 20 pustules, then we have to think of neonatal sepsis. But erythema toxicum neonatorum is a totally benign condition, does not require any treatment, right? Usually appears on day 3 to day 5 of life. What do you see here? So, this image has come previously in the FMGE exam Jan 2023. So, what you see here is, yes, can anyone answer? So, here we can see an area of discoloration which is slightly raised from the surface. So, these are nothing but capillary hemangiomas, okay. So, these are capillary hemangiomas. Again, as such, they do not need treatment unless, they are interfering with the, with the opening of eye or, for cosmetic purposes, they can be treated, but these are capillary hemangiomas, right? What do you see here? So, this is a neonate, okay, this is a neonate. So, Yasmin Ansari is telling wine stain. So, beta, this is not the port wine stain that we see. So, port wine stain typically we see in Sturge-Weber syndrome. So, we will be coming to that, okay. So, what do you see here? So, what we see here is, a unilateral swelling involving the head of the baby, right? It is mainly on one side, right? So, right side you can see this swelling is there, and if you have been given the information that this baby is 5-day-old, 5-day-old baby with such a picture, what is your diagnosis? What is your diagnosis here? So, 5-day-old baby with such a swelling of head, what is your diagnosis? So, yes, Sanhita, Mohit, Shivani, Karthik, Bunny, no, Marvik, yes. So, this is cephal hematoma. So, this is a collection of blood, that is cephal hematoma. Now, capered succedaneum is also a swelling involving the head. So, we must, know the differences between the two so that we are able to make out why we are telling it is cephal hematoma, why not capered succedaneum. So, we will be coming to the differences, but capered succedaneum usually would disappear by 48 to 72 hours, and it can be a diffuse swelling involving both sides, right? But this is a 5-day-old baby, this is a unilateral swelling, so it points towards cephal hematoma, right? And recently in the NEET PG 2023 exam, you got this X-ray also, a baby having a scalp swelling. So you can see it's not exactly a scalp swelling, it is a swelling involving the head. And if you do an X-ray, you can see there is a subperiosteal hemorrhage. So again, so this is right side, this is left side. So this is a subperiosteal hemorrhage involving the cranial bones. So this again, your diagnosis becomes cephalhematoma. Okay, cephalhematoma. Yes, very good. Gautam is telling suture is not crossed. Yes. So let us come to the important differences between cephalhematoma and Caput succedaneum. So cephalhematoma is nothing but a collection of blood. So it is subperiosteal hemorrhage. Subperiosteal hemorrhage involving the cranial bones. Involving the cranial bones. Right. While Caput succedaneum refers to edema in the layers of scalp. Nothing to do with the bone or periosteum. Okay. Edema in the layers of scalp, right? Layers of scalp. Now, because cephalhematoma is between the bone and its periosteum, cephalhematoma does not cross sutures. Does not cross sutures because each bone is going to have its own periosteum, right? So, if there are two cranial bones, so each bone has got its own periosteum. So, this is a collection of blood between the bone and the periosteum. So, it will usually not cross sutures, okay, usually not cross midline or sutures, right. But Caput succedaneum is edema in the layers of scalp, so can cross sutures, right. So, because this is the bone and this is the periosteum, so it has nothing to do with the bone and periosteum, it is edema in the layers of scalp. So, it can cross the, sutures. What else? Cephalhematoma takes time to appear also, disappears also. So, takes 24 to 48 hours to appear and disappears in 5 to 7 weeks. While Caput succedaneum is present immediately at birth, appears immediately at birth and disappears in 48 to 72 hours. Now, because cephalhematoma is a collection of blood, blood breaks down to what? Hemoglobin, heme, biliverdin, bilirubin. So, cephalhematoma will predispose to jaundice, but Caput will not. Right? So, that is how you can distinguish from a given swelling of the head whether it is cephalhematoma or Caput succedaneum. Okay? Right? Now, what is this? So, this is a device which is used in neonatal resuscitation, also used in the resuscitation of older children and adults. So, in neonatal resuscitation, we use it very, very frequently. So, this is a, what is it? What is it? Yes. So, it is commonly called ambu bag, but it is a self-inflating bag. Okay, self-inflating bag. Why do you call it self-inflating? Because you squeeze the bag and you leave it, even if you have not connected any gas supply to it, it will get re-inflated on its own. Okay, so it is a self-inflating bag, right? And this is a mask. So this is a self-inflating bag and a mask, right? And what else do you see? So this is called a reservoir. This bag-like thing here is called a reservoir. What is the function of the reservoir? So, the function of the reservoir is to, yes, so it is to increase the FiO2 delivered to the baby, and these are the oxygen tubings, right, the oxygen tubings. So, this is used for providing positive pressure ventilation. So, it is used to provide positive pressure ventilation during neonatal resuscitation, positive pressure ventilation, right? And when do you give positive pressure ventilation during neonatal resuscitation? What are the indications? So, if the heart rate is less than 100 per minute, or there is apnea, or there is gasping, you need to use it, right? The mask has to be tightly placed on the face or covering the mouth and nose of the baby. And the technique used is the EC clamp technique, okay, EC clamp technique, right, okay, right. So, that is about the self-inflating bag and mask. And when you are resuscitating a term baby, you start with room air. In preterm babies, we can start with a FiO2 of around 30%, right. Now, what is being done in this image? So, you are testing for something by, pressing on the sternum. So, this, technique by which you are pressing on the sternum and then releasing it and seeing in how much time the pinkish color is reappearing. So that is something known as capillary refill time. Okay. So this is capillary refill time, which is used, it is a technique used to assess the perfusion of neonates or infants. So the normal capillary refill time is less than 3 seconds. Okay. So somebody is telling it is chest compression. No beta. So chest compression we can do using two techniques. Either we can do a two thumb encircling technique like this. Okay. So we will put both the thumbs on the lower part of the body of sternum, and we can do like this two thumb encircling technique, or we can do the two finger technique like this. Okay. So using a single finger or thumb, we do not do chest compression, right? So this is capillary refill time to check for perfusion of the baby. What is this? So this is a device you must have seen in the neonatal intensive care units of your hospital, of your medical college. So this is a device where you keep the baby here. Okay, here the baby is kept, and you can see a overhead heating unit which is there. So this is called a, yes, no beta Amulya, Ravi Prakash, no, it is not an incubator. What is it called? Yes. So this is called a radiant warmer. Yes, this is a radiant warmer. Okay. So this you can see is a open care system. Okay, there is no closed box like thing. I'll show you a picture of the incubator, but this, remember, is a radiant warmer. Here the baby is kept here on this bassinet, and there is an overhead heating unit that is there. The baby gets heated by the process of radiation. Okay, the baby gets heated by the process of radiation here. Okay, and so this is a radiant warmer open care system. Okay, so there are various modes, manual control mode, servo control mode. So this is very commonly used in delivery rooms, in OTs where the baby is just born. You pre-warm the radiant warmer, receive the baby in this, keep in this for resuscitation. Okay, so radiant warmer, the process by which the baby gets heated is radiation, while the baby loses heat in a radiant warmer by convection. So loses heat by convection. Gets heated by radiation, loses heat by convection in a radiant warmer. Now this, on the other hand, is an incubator, right? So don't forget, this is an incubator. It is a closed kind of a system. So it is a transparent closed chamber kind of a thing. Inside it we keep the baby. So this will also keep the baby warm. Okay, so this is called an incubator. It is used mainly for preterm babies. It also helps in decreasing the insensible losses. Okay, so it is an incubator, and in the incubator the baby gets heated mainly by the process of convection. So convection currents, okay, convection, while the baby loses heat in an incubator by the process of radiation. Okay, loses heat by radiation. So it is just the opposite. In radiant warmer the baby gets heated by radiation, loses heat by convection. In an incubator the baby gets heated by convection and loses heat by radiation. So this you can see is a transparent box like thing. There are some openings through which you can put your hands inside and take care of the baby, right? Do any procedure that you want to do. Okay. Now what is being done here? So here there is a mother who has kept her baby inside her clothing such that the baby and the mother are in skin to skin contact. What is this called? Yes, have you seen one animal who keeps the baby in his pouch so that there is skin to skin contact? So very good, all of you. So this is KMC or kangaroo mother care. Okay, so kangaroo mother care. It is recommended to be done for all stable low birth weight babies, right? Okay, so baby is kept in skin to skin contact with the mother. Exclusive breastfeeding is done, and it promotes early discharge from hospital. So what is not a component of kangaroo mother care? So supplementary nutrition is not a component. Exclusive breastfeeding is to be done, right? So what are the advantages? So kangaroo mother care helps in decreasing. So it decreases the risk of. Hypothermia, neonatal hypothermia. It decreases the risk of neonatal sepsis. It decreases the risk of overall neonatal mortality. Okay, and there is better weight gain. Higher exclusive breastfeeding rates. Okay, better weight gain, higher exclusive breastfeeding rates. And there is early discharge from hospital. early discharge from hospital. So these are the advantages of kangaroo mother care, right? Kangaroo mother care, okay, for all stable low birth weight babies. Now coming to a case scenario based question. So here we have a male neonate delivered at 30 weeks gestation. So it is a preterm neonate. What do you mean by preterm neonate? So a neonate who is born at less than 37 completed weeks of gestation, okay. So it is a preterm neonate. So it is a preterm neonate who presented with severe respiratory distress immediately after birth requiring intubation. So I can see already you all are answering. So what is your diagnosis here? So here of course the baby is so preterm, so the lungs are not mature enough. There is deficiency of mature surfactant, right? So what you see here is, you can appreciate there is ground glass haziness of lungs, okay? Normally the lungs should have appeared black. Instead of black, what is happening? The lungs are appearing grey here. So there is ground glass haziness of lungs. You can see there is ground glass haziness of lungs. But you can also make out that there is presence of air bronchogram. So can you make out these linear radiolucent black areas? Okay. So they are, presence of air bronchogram. These are presence of air bronchogram. Why are they present? Because in respiratory distress syndrome or hyaline membrane disease, the problem is at the level of alveoli. They are collapsing due to deficiency of surfactant. But there is no problem with the airways. So there is air in the airways normally. Okay. So this is a typical case scenario of respiratory distress syndrome or hyaline membrane disease. Hyaline membrane disease, where you can see ground glass haziness of the lungs and you can see the air bronchogram, you can see collapse of lungs. So respiratory distress syndrome due to the deficiency of mature surfactant. Now what can you do to prevent respiratory distress syndrome? So to prevent respiratory distress syndrome, to prevent it, what we can do is we can use, what can we use? So we can use antenatal corticosteroids. Right? So we can use antenatal corticosteroids. Antenatal corticosteroids. Right? So antenatal corticosteroids, we can use either dexamethasone or betamethasone. And the dose is often asked also. So betamethasone if you are using, you have to use 2 doses. So 12 milligram per dose. 12 milligram, 2 doses, 24 hours apart. Okay? In the mother. While dexamethasone if you are using, it will be 6 milligram, 4 doses. Okay. So dexamethasone, 4 doses of 6 milligram each, 12 hours apart. And what is the respiratory distress scoring that is used in preterm babies with respiratory distress syndrome? What is the scoring system that is used? Yes. What is the scoring system that is used? So it is the Silverman score. So Silverman score is used for assessing the respiratory distress in a preterm neonate. While in a term neonate, what is the name of the score we use? Yes, a chocolate for those who answered it. In a term neonate, what is the name of the score that is used? So in a term neonate, the score that we use is, so term neonate, the score that we use is the, so well Murugan gets the first chocolate. So term neonate, Downey score. Right, Downey score. Okay. So moving ahead, what do you see here? So this image was there in the recent INI-CET exam conducted in May 2025. So what you can see here is, you will usually find this in term babies or near term babies, right? And the babies born by cesarean section are more at risk for this condition. So this is known as, yes, so lots of chocolates to all of you and keep answering like this. Okay, so what do you see here? So this is if you get a case scenario like this, so this is a term or a near term neonate with mild to moderate respiratory distress soon after birth. Mild to moderate respiratory distress, and this baby is born by lower segment cesarean section. So this is a typical case scenario where we are going to suspect, TTNB, okay, transient tachypnea of newborn or TTNB. So why TTNB? So TTNB because you can see here that there is fluid in the interlobar fissure. You can see in general there is perihilar streaking and you can see the hilar prominences, there is fluid in the lung. So fluid in the fissures also. So this is typically what we see in TTNB, okay, transient tachypnea of newborn, okay. TTNB or transient tachypnea of newborn is the diagnosis here, right, okay. Moving ahead. So next what we see, so just give me a moment, my presentation is stuck. Just give me a moment, yeah. So what do you see here? So this is a spotter, has come so many times in standalone questions in all the exams, in FMGE exam, in NEET PG exam, in INI-CET exam, multiple times. So what do you see here? Right? So what do you see here? So you can see that there is, there are bowel gas shadows in the thorax. Can you appreciate these bowel gas shadows in the thorax, right? And there is mediastinal shift. The heart shadow has shifted to the opposite side, right? So this is the typical, X-ray that you get in congenital diaphragmatic hernia. Very good, awesome. I can see all of you answering. So this is a typical X-ray that you get in congenital diaphragmatic hernia, okay, congenital diaphragmatic hernia. So you can see bowel gas shadows in the thorax, you can see the mediastinal shift, and there is pulmonary hypoplasia. So this is congenital diaphragmatic hernia. It can present with respiratory distress immediately after birth, with a scaphoid abdomen and with mediastinal shift to the opposite side. So it is most commonly, left side is more common, and the most common variety is the posterolateral or the Bogdalek variety. So posterolateral or the Bogdalek variety is the most common type, okay. Bogdalek variety, okay. And if a case of suspected or antenatally diagnosed congenital diaphragmatic hernia, what is absolutely contraindicated? Again, this has come as so many times. So what is contraindicated? Yes. What is contraindicated? Waiting for your answers. Come on. So absolute contraindication in this condition is, so there is bag and mask. Very good, Megha, Tanmay, Ravi Prakash. So bag and mask ventilation is absolutely contraindicated in this condition. Absolutely contraindicated. So instead of baby's condition improving, it will worsen if you do bag and mask ventilation here, right? If required, you have to intubate the baby and do bag and tube ventilation. And remember, there is always a pulmonary hypoplasia associated with it. So the most common cause of death in a baby with congenital diaphragmatic hernia is pulmonary complications or pulmonary hypoplasia, right? Okay. So moving ahead. Why is my PPT getting stuck? Just give me a moment. Yeah. So what do you see here? What do you see here? So this we already saw actually a picture in the beginning of the class. So this is this defect. What is this defect known as? So you can see that the bowel loops are contained inside a sac, and from the tip of the sac the umbilical cord is arising. So yes, very good guys, this is omphalocele. And a similar condition with which you can get confused. So what is this? So this you can see here the bowel loops again are coming from an abdominal wall defect, but here this is coming just lateral to the umbilical cord. You can see the umbilical cord separately here, right? So what is this condition called? So this condition is known as gastroschisis. Okay, very good. So these are again spotters, gastroschisis. So gastroschisis, the bowel loops are not covered with any membrane. So the bowel loops are more edematous and they can be necrotic, and you cannot start feed early in these babies. But omphalocele has more chances of associated congenital anomalies as compared to gastroschisis. Okay, right? Now what is being done here? So this is a neonate. In this neonate, what someone is doing is someone is pressing the sole of the baby and then releasing it and trying to see whether the soles are appearing. Yes, in this case I am sure you can appreciate the soles of the baby are appearing yellowish or not. So if you can see what is being done here. So here we are checking for no alia, we are not checking for pallor. What are we checking for? So we are checking for neonatal jaundice. Okay, we are checking for neonatal jaundice or hyperbilirubinemia. So remember, in neonates, we do not check for hyperbilirubinemia in the eyes or the sclera. We check on the general skin surface. So we check on the forehead, on the sternum, on the abdomen, thighs, legs and palms and soles. So there's a modified Kramer staging. That means till how much the baby is yellow in color. Based on that, you can get an approximate idea of the baby's bilirubin level. So that is called modified Kramer's rule. Okay. So it gives you an idea about the bilirubin level of the baby. Okay. So if the sole, palm and sole of the baby is yellow, that means the bilirubin level is approximately greater than or equal to 15 milligram per dl, and the baby will probably require treatment. Okay. Now what is the treatment for neonatal jaundice? Who will tell me what is the treatment for neonatal jaundice? The first line treatment for neonatal jaundice. Yes, waiting for your answers. The first line treatment for neonatal jaundice is, what is this that is being done here? So it is a phototherapy, right? It is phototherapy. So you can see in phototherapy, the baby is kept under the blue light like this. So baby is kept under the blue light, right? And the eyes of the baby should be covered and the genitalia should be covered using a diaper. So the eyes and the genitalia of the baby should be covered. The baby is kept under the phototherapy unit. So the most effective spectrum of light is 450 to 460 nanometer for providing phototherapy. Phototherapy is the first line treatment for neonatal jaundice. How does it act? So there are three mechanisms. So they are, what are they? So photoisomerization, structural isomerization and photooxidation. So these are the three mechanisms by which the phototherapy acts. Out of these, the most important mechanism is structural isomerization, whereby the bilirubin is converted to lumirubin. So bilirubin is converted to lumirubin, which is excreted through the kidney without conjugation, right? So that is how the phototherapy acts. And there are some important adverse effects of phototherapy, like the bronze baby syndrome. The color of the skin of the baby becomes darker after the baby has received phototherapy. So there can be bronze baby syndrome. Okay, so there can be bronze baby syndrome. There can be some other adverse effects also, like watery diarrhea. So side effects, we are talking about side effects of phototherapy. So bronze baby syndrome, watery diarrhea, dehydration, okay, hypocalcemia, retinal toxicity. So because it causes retinal toxicity, we are covering the eyes of the baby by a eye band sort of thing. So retinal toxicity and gonadal toxicity or mutations. Retinal toxicity, gonadal toxicity or mutations, right? And if the jaundice is very, very severe, we might have to go ahead for exchange transfusion. So daily life course is asking, when do we do exchange transfusion? So in severe cases of neonatal jaundice, so there are some charts or graphs available that at 48 hours of life, if the bilirubin is more than this, do phototherapy. If the bilirubin is more than this, do exchange transfusion. Again, at 72 hours of life, this is the cutoff for phototherapy, this is the cutoff for exchange transfusion. So if the bilirubin levels are very high, we cannot sit and wait for the phototherapy to act. So in that case, we have to do exchange transfusion. What we do there? We take out the blood of the baby and we replace it with fresh blood. Okay. So with the blood of the baby, we are also taking out the bilirubin. In case of RH isoimmunization, we are also taking out the antibodies. Okay, and so on. And if there is RH isoimmunization, you can also use IVIG. Okay. So IVIG and exchange transfusion to be used in severe cases, especially erythroblastosis fetalis. Okay, right. Moving ahead, what do you see here? So a neonate developed feed intolerance, abdominal distension, and this X-ray picture. So this is, yes, waiting for your answers. So this is a case of NEC or necrotizing enterocolitis. Now tell me which stage of NEC it is. So necrotizing enterocolitis in stage, so there are three stages, 1, 2, 3, each has got a A and a B. So 1A is when there is occult blood in stool positive. 1B is when there is fresh blood in stool. Okay, fresh blood in stool. What is 2A? So in 2A, we get something known as, yes, so this is pneumatosis intestinalis. What do you mean by pneumatosis intestinalis? That means that, normally in the lumen of intestine, there is always air. But if you get air or gas in the wall of intestine, can you appreciate that there is a double lining of the wall of intestine because there is air in between the layers of wall of intestine. You can see double lining of the walls of intestine, right? So there is air not only in the lumen but in the wall of intestine. So that is called pneumatosis intestinalis. So 2A is pneumatosis intestinalis. 2B will be if you get portal vein gas shadows. Portal vein gas shadows. So you will get some gas shadows like this in 2B, okay, in the portal vein area. And 3A would be if you are getting evidence of peritonitis. And what will happen in 3B? 3B, you will have perforation of the intestines. So you can see the gas under the diaphragm or pneumoperitoneum. So pneumoperitoneum or gas under the diaphragm due to perforation of the intestine. Stage 3B NEC. You can get this feature in an older child or adult also. Whenever you are getting gas under the diaphragm, it is usually due to some perforation of the bowel. Okay. So in neonates, it is usually secondary to necrotizing enterocolitis, the most severe stage. Now moving on to some important images from general pediatrics, right? So what is this device used to measure? Come on, I want all of you to answer. And yes, pneumoperitoneum, very good. Priya is also known as football sign. Okay. So what is this? So this is a measuring tape. You can see the red, yellow and the green zones. So what is this device and what is its use? So this device is known as, very good, I can see all of you answering, it is a Shakir's tape and it is used by health workers to measure the mid-arm circumference or the mid-upper arm circumference. It has got a red, yellow and a green zones, right? So red zone is when the mid-arm circumference is less than 11.5 centimeters and it signifies severe malnutrition. Severe malnutrition. Yellow zone is when it is between 11.5 to 12.5 centimeters, so borderline nutritional status. And when it is coming in the green zone, so the mid-arm circumference is more than 12.5 centimeters, that is normal nutritional status, right? Okay. What is this device used to measure? What is being measured here? So this you can see what is being measured here is the skin fold thickness is being measured. Yes, can you tell me the name of the device? Name of the device? So we are measuring the skin fold thickness and the name of the device here is the Harpenden calipers. Very good. Harpenden calipers. What are the areas where we usually measure the skin fold thickness? So it is usually measured over the biceps area, the triceps area, the suprascapular area and the subscapular area. And you have WHO growth charts with which you can interpret the values. Previously, one Tanner's chart also used to be used, right? Most commonly we measure it over the triceps area, but you can measure over any of these areas, okay? What is this device? I'm sure all of you must have seen this device in your pediatric OPDs or wards during your clinical postings. What is this device? Yes? Waiting for your answers. So this device is used to measure the length of the infants and babies. Yes, very good guys. So this is an infantometer. So this is an infantometer. So what you do is you lie the baby supine here and you need one person to hold the baby and keep the knees of the baby extended, and there is a fixed board at the head end, there is a movable board at the foot end, and you can take the direct reading from this ruler. So this is an infantometer for measuring the length of the baby used up to 2 years of age. Beyond 2 years, of course, we all know you must have got your heights measured when you entered your MBBS, yes, and many a times at school also. That is, what is the device used for measuring height? It is the stadiometer, okay, right. Now, what are these graphs showing you? So, there are some graphs which can come as together like this, match the column kind of question, or they can come as separate standalone graphs. So, you have to tell me what do each of these lines represent. Yes, so if we talk about A, so A you can see that there is a maximum growth in some organ in between 4 to 8 or 4 to 10 years of age. So A is representing the lymphoid growth, okay, lymphoid growth, lymphoid growth. What is B representing? the growth curve B, what is it representing? So it is showing that maximum growth is happening in the first 2 years of life. Thereafter, not much growth is happening. So B is representing the CNS growth. We know maximum brain development happens in the first 1 to 2 years. Okay, so B is representing the CNS or brain growth. What about C? So C is a sigmoid shaped graph. There is a period of accelerated growth, then less growth, then accelerated growth again during puberty. So accelerated growth during infancy, then somewhat slow down, then again accelerated growth. So this is the somatic growth. Okay, somatic growth pattern, or the growth of height or stature takes place like this. Okay, somatic growth. And what does D represent? So D shows that not much growth is happening till 9 or 10 years, and after that suddenly a lot of growth or development in a particular organ is taking place. So what does it represent? So it represents, so D represents the gonadal growth. Very good. Okay, so D represents the gonadal growth. So they can come as standalone questions also, or they can come as match the following question as well. Now, you can get a case scenario where you have to use, growth charts. So if growth charts are given in the question, suppose Aditya, a 2-year-old child is given to you, has a length of 70 centimeters. Is it normal or not? So ideally, we need to plot it on a growth chart and see. So this is a growth chart, height for age for boys. So 2 years, 70 centimeters we have to plot. So can you see? So this is 2 years and this is 70 centimeters. So if I plot it, where is it falling? So 70 centimeters and 2 years, right? So it is falling. Where is it falling? It is falling here. So it is falling below the 3rd percentile line. Can you see? This is the 3rd percentile line. Okay. So this line you can see is the 3rd percentile line. Okay. And this value is falling below the 3rd percentile. So this value is falling below the 3rd percentile. So this is the 3rd percentile line and this value is falling below the 3rd percentile line. So what is your interpretation? So this child has got short stature. Okay, this child has got short stature, right? And yes, you are right, around 2 years of age, Sanhita, the height of a child is almost half of the adult height. And we also have some rules of thumb, like at 1 year. So at birth, what is the length of a child? So at birth, the length of the child is usually around 50 centimeters. By 1 year, it usually becomes around 75 centimeters. By 2 years, it usually becomes around 90 centimeters. And you have a formula also for expected height. So expected height is equal to 6x plus 77, where x is the age in years. But the most accurate value, you get it when you plot it on the growth chart. Okay. So moving ahead, what is your diagnosis here? So if you get a serial tracing of the growth of a child, you can see that there is a child whose growth, so this is the 3rd percentile line. If this is the 3rd percentile line, you can see that there is a child whose growth is continuously below the 3rd percentile for most of the childhood, and later he is catching up and coming to the 50th percentile. So what is this phenomenon known as? So growth is staying below the 3rd percentile most of the childhood, and then it is catching up and coming at the 50th percentile. Yes, so this is a typical case scenario of constitutional delay in growth and puberty. So this is constitutional delay in growth and puberty. So there was a delay in the growth, but the ultimate final height attained is normal. Okay, ultimately, finally, the growth has come to 50th percentile. So constitutional delay in growth and puberty is your diagnosis here. Okay, right? Moving ahead, what do you see here? So we already have it written. So here you have, some dryness of the conjunctiva or conjunctival cirrhosis. In the next picture, you can see some triangular areas like this, pearly white foamy lesions on the sclera, and these are called Bitot spots. You can have some corneal drying, and you can even have corneal ulcers. Now, what are all these features suggestive of? In which condition can you get all these features? Yes, I can see all of you answering. So this is a vitamin A deficiency. So these all are features of vitamin A deficiency. So if there is a feature of vitamin A deficiency, you must supplement with vitamin A. So how much vitamin A you will give? So if the child is less than 6 months old, less than 6 months age, you will give 50,000 units. Okay, 6 months to 12 months, you will give 1 lakh units. Beyond 12 months, you will give 2 lakh units. And in order to treat vitamin A deficiency, you give one dose at diagnosis, the second dose 24 hours later, and a third dose 2 to 4 weeks later. Okay. Now, what else do you see? So, these are some other features of micronutrient deficiency. What you can see here is angular cheilitis. You can see oral ulcers or aphthous stomatitis. You can see glossitis. So, all these are features of vitamin B complex deficiency. Okay, to be more specific, they are mainly seen in riboflavin deficiency, vitamin B2 or riboflavin deficiency, right? And what do you see here? So, in the last picture, what you see is a Casals necklace. So, in the last picture, what you see is there is a lesion around the neck, okay, in the exposed parts of the body. It is photosensitive. It is known as Casals necklace, and it is due to which deficiency? Yes, Casals necklace is seen in which condition? So, very good. I can see most of you answering it is due to niacin deficiency, and the name of the condition is called pellagra. So, pellagra, niacin deficiency. Can you tell me a metabolic disorder, an inborn error of metabolism where you can get, this Casals necklace kind of a thing or pellagra like rash? So, again a chocolate for who answers this question. So, can you tell me which metabolic disorder you can get this Casals necklace like rash or pellagra like rash? Yes, so it is heart nerve disease. Wow, so many of you answering, right? Very good. So, it is heart nerve disease where you can get this pellagra like rash. Okay, right. So, moving ahead, if you are getting such a rash in a child who is having diarrhea, okay, and you can see that these are rashes around the orifices mainly, rashes around the oral cavity, on the fingers, around the genital area, diarrhea is there, right? So, these, yes, very good. I can see all of you answering. So, this image has been given in the FMGE exam recently. So, this is acrodermatitis enteropathica, and this is due to zinc deficiency. Acrodermatitis enteropathica due to zinc deficiency. Okay, the treatment would be you have to give high dose zinc supplementation. Okay, zinc supplementation, right? And poor wound healing and all is also there. Now, if you are getting a malnourished child who has not got any edema, all bones and everything are very clearly evident, it is all like total loss of subcutaneous fat. So, severe malnutrition without edema. What is this condition known as? Very good, Tulasi, Ravi Prakash, Prakhar. So, it is marasmus. Okay, marasmus, severe malnutrition without edema. If there is severe malnutrition with edema, so with edema if it is there, then that would be known as kwashiorkor, right? So, many a times you have got questions on kwashiorkor and marasmus. So, kwashiorkor, the salient features are edema is present, okay, and the child has poor appetite. So, edema, poor appetite, and there is apathy, lethargy or listlessness. These are the salient features of kwashiorkor. While in marasmus, the child has not got any edema, okay. What do you see here? So, these are some of the skin changes that you can see in a child with severe malnutrition. It just appears that, just like if you have seen some old buildings where, the flakes of paint keep coming out. Similarly, here you can see that the skin is all peeling, right? So, it is called flaky paint dermatosis. Flaky paint dermatosis. It is one of the features of severe malnutrition mainly seen in kwashiorkor, flaky paint dermatosis. And what do you see in the hairs of babies or children with severe malnutrition? So, alternate bands of hypopigmented and pigmented hairs. So, it is known as something known as flag sign. Okay, flag sign, again a feature of severe malnutrition, more common in kwashiorkor than marasmus. Okay. Now, there is this child with short stature. So, you have been given a child with short stature and some other abnormalities. And as you can see here, the short stature mainly involves the limbs. So, limbs are much more shorter as compared to the trunk. So, limbs are mainly short as compared to the trunk. And what you can see here is, you can see that there is, you can see that there is trident hand. Trident hand. So, is my screen visible? Yes, okay. So, trident hand, okay. So trident hand, and what you see here is, in this x-ray what you see is a champagne glass pelvis. So champagne glass pelvis, right? So what is your diagnosis here? Yes, what is your diagnosis here? Very good. So I can see most of you answering. So our diagnosis here is achondroplasia. Okay, achondroplasia. And achondroplasia, lots of times you get questions, what is the mode of inheritance of this condition? So the mode of inheritance of achondroplasia is autosomal dominant. It is a typical example of autosomal dominant inheritance. Okay, right. Now what is this condition? So this is a very interesting condition. You try touching both of your shoulders to each other. Are you able to? I am not able to do that. Can you touch both of your shoulders to each other anteriorly? No. But this individual can touch both of their shoulders to each other anteriorly. So this is a condition, very good bunny. So this is a condition which is known as cleidocranial dysostosis. Cleidocranial dysostosis, which can be a potential question for you. Cleidocranial dysostosis. This is a condition where there is absence of clavicles. So there is usually bilateral absence of clavicles. This condition also has autosomal dominant inheritance. There is a large anterior fontanelle and delayed closure of anterior fontanelle in them. There is delayed dentition, and you can even get supernumerary teeth. Okay, delayed dentition, and you can get supernumerary teeth. What do you mean by supernumerary teeth? So these individuals, when they are adults, they can have even more than 32 teeth. They can have 36 teeth, 38 teeth, like that. So supernumerary teeth. Right? So cleidocranial dysostosis. Now, at what age a child is able to do this? That you hold the child in ventral suspension and the child can move the head above the plane of rest of the body. So that means some neck control has started to appear. So this is at 3 months of age. This is again not parachute reflex. So you can, for doing a parachute reflex, you have to hold the child like this and you suddenly lower the baby and the child will spread both the upper limbs and the lower limbs to avoid falling on face. So that of course would be more evident in a video than a photo like this. But in this question you are being asked that at what age a child is able to do this. That means that a child is able to hold the neck above the rest of the body. So this is at 3 months of age when partial neck control has begun to appear. Now what is being done here? So a child is bringing the hand to midline as if looking at his own hands. This is a phenomenon which is known as hand regard. Hand regard again is a developmental milestone which comes around 3 months of age. After this the child is going to start using the hands. Now what do you see here? So here the child is able to hold small objects. But is he able to hold just with his thumb and index finger? No. Okay. He is taking the help of other fingers also. So this is, what is this? So this, of course, it is a pincer grasp, but it is immature. Okay, immature or assisted pincer grasp. Immature or assisted pincer grasp. So at what age this comes? Yes, immature or assisted pincer grasp comes at the age of 9 months. Very good. Okay, 9 months. Now what do you see here? The child is able to hold a small object using just the thumb and the index finger. Now I hope you understand what is the difference between immature and mature pincer grasp. Okay. So this is mature pincer grasp and this usually comes at around 12 months of age. Okay, 12 months age. Right. Now coming to the drawing skills of a child. So can you tell me when can a child copy a straight line? So remember, line has got 2 ends, so a child can copy a straight line at 2 years. A rectangle has got 4 vertices, a child can copy a rectangle at 4 years. Now in between comes the circle. So circle has a round like a thing, like the digit 3 also has round things. So 3 years the child is able to copy a circle and 5 years the child is able to copy a triangle. Easy to remember? Okay. Now, there are some cube related milestones as well, okay. So, one is, the most important is tower of cubes. So, tower of a child of 2 years is able to make a tower of 6 cubes. So, tower of 6 cubes comes at 2 years, okay. So, that means the number of cubes a child can put into tower is age into 3. So, age into 3 is the number of cubes the child can put into tower. Okay, that means one on top of the other like this. Okay, so at 3 years the child can put 9 to 10 cubes in tower. Now, apart from that, the child can also make some interesting patterns using cubes. Like a child can make a train without a chimney. So, a train without a chimney comes at what age? So, it comes at around 2 years of age. Train with chimney comes at around 2.5 years of age. Right? A child is able to make a bridge like this at 4 years, a gate at 5 years, and these steps at around 6 years of age. So, these are the usual ages at which the child can make these cube related milestones. Okay. Now, what is the child doing here? So, the child is enjoying playing like this. So, that's called playing peekaboo. So, playing peekaboo again is a developmental milestone that usually appears at around 10 months of age. And when does waving bye-bye appear? So, waving bye-bye usually appears by 9 months of age, right? 9 months of age, right? Okay, what is the use of this device? So, no, it's not a necklace. What is it? So, this device, what is the name of this device and what is it used for? So, this, waiting for your answers. Yes, which device is this? So, this is a orchidometer, right? So, this is a orchidometer which is used to assess the testicular size or testicular volume, used to assess testicular size. So, used in the assessment of puberty. So, what we do is we stretch the scrotal skin and compare the testicular size and see it is corresponding to which ovoid body. So, if the testis, the size of the testis is similar to this one, then the approximate volume of testis is 5 cc or 5 ml. So, like that we get an approximate idea of the testicular size. It is used in the assessment of puberty in boys. Okay. Now, Tanner staging we all are aware of. So, in females, what do we look at? We look at the development of the breast and the pubic hairs. Okay, breast and pubic hairs. So, stage 1, of course, the breast is going to be prepubertal. Stage 2, there will be breast bud enlargement and enlargement of the areola as well. Stage 3, there will be further enlargement. What is important in stage 4? There will be formation of a secondary mound. That means if you look at the breast and from the side profile, there will be a secondary mound like this. So, this is the nipple areola and there will be a secondary mound above the level of the breast. So, that is what you see in stage 4. And stage 5, it will be like a mature adult. Okay. Now, pubic hairs, again stage 1, there will be no pubic hairs. Stage 2, it will be sparse growth around the labia minora. And then stage 3, further enhancement of the growth. Stage 4, thick adult type growth. And stage 5, this growth spreads to the medial aspect of the thigh as well. Okay. Now, Tanner staging in male, it is done on the basis of what? It is done on the basis of development of testis, development of penis and the pubic hairs. So, in prepubertal age group, the testicular volume is less than 4 cc, okay, less than 4 cc. Then what happens? The first sign of puberty. So, first you tell me what was the first sign of puberty in females. So, in females, the first sign of puberty is, yes, in females, waiting for your answers. The first sign of puberty in females is, come on. So, it is development of breast or thelarchy. Very good, well, Murugan. So, it is thelarchy. And the first sign of puberty in males is, what is the first sign of puberty in males? So, it is testicular enlargement, which you can assess using a orchidometer. So, the first sign of puberty in males is testicular enlargement. So, stage 2, what is going to happen is enlargement of the scrotum and testis. Stage 3, there will be enlargement of the penis also. The length will increase first and the next stage there will be enlargement in the length as well as the girth of the penis. And stage 5, it will be like the adult genitalia. Similarly, stage 1, no pubic hairs. Stage 2, sparse pubic hairs at the root of penis. Stage 3, further increase in pubic hairs. Stage 4, it will become more curly and just like adult but does not spread to the medial aspect of thigh. Stage 5, it spreads to the medial aspect of thigh. So, that is how you assess puberty by the Tanner staging or sexual maturity rating. Now, these are some intravenous cannulas. You must know which size or which color is for which age group. So, in neonates, we usually use either the purple one. So, in neonates, we use the purple one that is 26 gauge or the yellow one that is the 24 gauge. So, these are the two sizes that we usually prefer to use in neonates. Right, in preterm neonates, of course, you will be using the smaller size that is the 26 gauge for preterm. Right. So, yellow is 24. Purple is 26 gauge, okay. Then blue of course will be 22 gauge, pink is going to be 20 gauge, green 18, Gray 16 and so on. Okay. So in children, we mostly use the 22 gauge or blue cannula. In older children, we can use the 20 gauge or pink cannula. Okay. Right. So moving ahead. Now, how do you interpret this pedigree? So this has come recently in one of the exams, in the FMGE exam, July 24. So if you get a pedigree like this, carefully analyze this pedigree. What you see here is, here there is a female who is affected and all her children you can see are affected. All her children are affected. Now this male is affected, no children affected. This female is affected. This female is affected, again all her children are affected. This female is affected, again all her children are affected. So what kind of inheritance it is? Yes, very good. So Bunny, behind the camera, Tasmina, Kia, Sanhita, Jami. So it is mitochondrial inheritance, or it is also called maternal inheritance. So why is this happening, that all children of a affected female are affected, not the affected male? So the baby gets all its mitochondria, all the power from the mother, right? So, there is this ovum and there is the nucleus of the ovum and there are the mitochondria in the cytoplasm. What is going to happen is the sperm head is only going to penetrate this, but rest of the entire thing, so some DNA is coming from the father, but everything else is coming from the mother, right? Everything else rest is coming from the mother. So maternal mitochondria, if they are defective, all the babies are mostly going to have it. So that is mitochondrial inheritance, right? So some examples are like Kearns-Sayre syndrome, Leber's hereditary optic neuropathy, okay, Lake disease, Leber's hereditary optic neuropathy. Then you have this MELAS, mitochondrial encephalopathy, lactic acidosis, stroke-like episodes, MRF, myoclonic epilepsy, rapid red fibers. So these are some of the examples of mitochondrial inheritance, okay, right? Now, what kind of inheritance do you see here? So, what you see here is, wherever some children are affected, so first thing you notice is that both males and females are affected. Yes? Okay. What else? You can see that here this boy and girl are affected and one of the parents is also affected. This child is affected, one of the parents is also affected. This child is affected, one of the parents is also affected. So, whenever a child is affected and one of the parents is also affected, it has to be dominant inheritance. Dominant inheritance. Both males and females are affected almost in equal numbers, so it appears to be autosomal dominant inheritance. How are we more sure about it? So it is an autosomal dominant inheritance. It cannot be X-linked. Why? Because what we can see is male to male transmission. What we see here is this diseased male is transmitting it to the son also. So in X-linked conditions, remember, father's X chromosome never goes to the son. What goes to the son is the Y chromosome. So if a disease is going from father to son, it cannot be X-linked inheritance. It has to be autosomal, right? So father to son transmission rules out X-linked inheritance. So it is an autosomal dominant condition, right? What do you see here? So this pedigree came in the NEET PG 2024. So there was this case scenario and it was asked which of the conditions follow this inheritance. So the answer was Wiskott-Aldrich syndrome. So what is glaring in this pedigree is, it is the males who are mainly affected. The females are carriers. So females are carriers here. So this is a condition which is X-linked recessive. So X-linked recessive inheritance. X-linked recessive inheritance. And some of the examples we know are Wiskott-Aldrich syndrome, hemophilia, okay, hemophilia and so on, right? So here what you can see is father to son transmission is not there. So this son is affected but the father is not affected. Son is affected, father is not affected. Son is affected, father is not affected, but the mothers are the carriers, okay. So it is X-linked recessive, okay. Now what is the diagnosis in this child who has intellectual disability? Intellectual disability is the new name for mental retardation and there is large testis and you can see the head is also large head, there is this elongated face, large ears, large jaw, and these children when they become adolescent they have large testes and there is intellectual disability. This condition is more commonly seen in males, so the Diagnosis here is, I can see most of you answering yes. So this is Fragile X syndrome. Okay, Fragile X syndrome. It is a trinucleotide repeat disorder due to the abnormal increase in the number of CGG repeats to more than 200. Okay. What do you see here? So first tell me, what is the name of this investigation? What is the name of this investigation where you can see all the chromosomes neatly arranged? So here this is name of the investigation. So this is a normal picture which is showing, if you count the total number of chromosomes, it is 46, and there are 2 X chromosomes, no Y chromosomes, so it is 46 XX. So this is a normal karyotype that we see in a girl. Yes, so the name of this investigation is being asked here. It is called a karyotype, okay, where we look at all the chromosomes. Now, can you notice any abnormality in this karyotype? So what is the diagnosis based on the result of this karyotype? Can you notice any abnormality in this karyotype? Yes, waiting for your replies. So what is the karyotype here? Any abnormality in this karyotype? Very good. Nasreena, Mash, Alia, Robo. So this is so you can see that all the chromosomes have 2 copies except chromosome 21 here. So this is trisomy 21. So our diagnosis is trisomy 21 or Down syndrome. So if you look at the total number of chromosomes here, if you count, instead of 46, it is going to be 47, right? What is your diagnosis here? So again, these are clinical features compatible with a diagnosis of Down syndrome. You can see, what all do you see here? You can see depressed bridge of nose. You can see the epicanthic fold over the medial canthus. You can see the mongoloid slant of the eyes, okay? Right? They can sometimes be the protruding tongue. You can see the curved little finger or clinodactyly, and they can be the simian crease, a single transverse palmar crease can be there. The simian crease, there can be sandal gap, increased gap between the great toe and rest of the toes. So all these are clinical features which are compatible with a diagnosis of Down syndrome or trisomy 21. What do you see here? So if a newborn baby is born with edema of hands and feet, so you can see lymphedema of hands and feet, and you have a shield-shaped chest with widely spaced nipples, shield-shaped chest with widely spaced nipples, loose skin folds around the neck, and you have a low posterior hairline. So all these features are compatible with a diagnosis of, yes, I can see most of you answering correctly. Munisa, Deepak, Sanhita, Shalupriya, SS, Megha. So this is Turner syndrome. Yes, this is Turner syndrome. Okay, right? Turner syndrome is always seen in females. And there is short stature, okay, short stature is there, cubitus valgus is there, but the intelligence is normal, there is no intellectual disability. And what do you get on a karyotype? So what do you see in this karyotype? Can you tell me? So this karyotype picture is showing you that if you count the total number of chromosomes here, instead of 46, it is 45 chromosomes, okay, there are 45 chromosomes, there is a single X chromosome and no Y chromosome. So this is the karyotype here, 45XO, which is again goes in favor of Turner syndrome. So total number of chromosomes 45, no Y chromosome, a single X chromosome. I am sure all of you are going to diagnose it. Okay. Now, what does this child have? So this again is a child who has intellectual disability, that means mental retardation. There is ejection systolic murmur best heard in pulmonary area, that means there is pulmonary stenosis. So this child has intellectual disability, pulmonary stenosis, there is some facial dysmorphism. What you see here is anti-mongoloid slant. So the slant of eyes is opposite to what you saw in Down syndrome. So that is called the anti-mongoloid slant of eyes. And what else have you got? You've got low set ears, and you've got webbed neck or the loose skin folds around the neck. So webbed neck. So all these, some of these features are similar to what you saw in Turner syndrome. Like, webbed neck is there, low set ears can be there, okay, and there will be short stature. So this is a child who has features similar to Turner syndrome, but it is not Turner syndrome because there is intellectual disability, there is this anti-mongoloid slant of eyes, and there will be delayed puberty, and this condition is known as Noonan syndrome. Okay, Noonan syndrome. It has got autosomal dominant inheritance. It can be seen in both boys and girls. And most common heart disease in Noonan syndrome is pulmonary stenosis, while most common heart disease in Turner syndrome is bicuspid aortic valve followed by coarctation of aorta. Okay. Now, who will tell me what is the diagnosis based on this karyotype? Come on. So, we have seen a lot of karyotypes now. I am sure all of you will be able to diagnose as soon as you get one. So, what do you see here? There are two chromosomes, two copies of each chromosome except chromosome 18. So, you have 3 copies of chromosome 18. So, it is trisomy 18. So, our diagnosis is Edwards syndrome. Okay. Edwards syndrome. Alright. And what are the clinical features that you can get? You can get this rocker bottom hand and foot, rocker bottom foot. So, rocker bottom foot you can get just like a rocking chair, rocker bottom foot, you can get microcephaly and you can get overlapping fingers. So, these all are features of Edwards syndrome or trisomy 18. Right? Okay. Now, if you are getting some scalp defects, cutis aplasia, you are getting defects of the limb, you are getting polydactyly, you are getting increased distance between the canthus of eyes and the imaging shows hollow prosencephaly, internal malformations. So, all these are compatible with the diagnosis of trisomy 13 or Patau syndrome. So, Patau syndrome is a much more severe condition as compared to Edwards syndrome, risk of many internal malformations. What do you get here? So, you are getting a child with micrognathia and retrognathia. So, you can appreciate that the chin is small and more posteriorly placed. So, there is micrognathia and retrognathia. So, it is seen in which syndrome? So, it is seen in, yes, waiting for your answers. So, it is seen in Pierre-Robin sequence. Very good, Aki, Sanghita. So, Pierre-Robin sequence. So, in these children, there are more chances of atrial septal defect and there is glossoptosis, falling of tongue, airway related issues may require tracheostomy. What do you see here? A child with tall stature presented with the physical findings shown here. What is the diagnosis? So, you can see pectus excavatum. You can see long fingers which is called arachnodactyly, chest deformity or pectus excavatum, and you can see a positive thumb sign. So, if you put your thumb like this and you close your fist, the thumb is protruding beyond the ulnar border. So, all these are features compatible with Marfan syndrome. And in Marfan syndrome, you also get lens dislocation of the eye, superolateral dislocation of the lens of the eye. Superolateral dislocation of lens of eye. Who can tell me that similar skeletal features can be seen in which metabolic disorder? Similar skeletal features can be seen in which metabolic disorder? Yes. So, homocystinuria is a condition where you can get similar features involving the skeleton, just like Marfan syndrome. What is the name of this investigation used to diagnose genetic disorders? Yes, so this investigation is used to diagnose, it can be used to diagnose chromosomal disorders like Down, Turner also. It can be used to diagnose submicroscopic deletions like Williams syndrome, okay. And it can also be used to diagnose others like you have this 22q deletion, 22q11 deletion, Digeorge syndrome, right. So, this investigation very good all of you. So, it is called FISH. What is FISH? So, fluorescent in situ hybridization, fluorescent in situ hybridization known to so it can be used to diagnose a known locus, okay, when you know what is the mutation that you are expecting. What do you see here? So, in the fundus here what we see is a cherry red spot. So, cherry red spot is seen in which metabolic disorders? So, cherry red spot can be seen in, so it can be seen in GM1 gangliosidosis, Tay-Sachs disease, okay, GM1 gangliosidosis, Tay-Sachs disease, Niemann-Pick disease. It is usually not seen in Gaucher disease, okay, right. What do you see here? A child with generalized hypotonia, And there is cardiomegaly, and there are some ECG changes also like tall QRS complex, short PR interval, hypotonia. So skeletal muscle involvement as well as cardiac muscle involvement. So our diagnosis becomes, so what is our diagnosis here? Very good, Shalupriya. So our diagnosis here becomes Pompe disease. And what is the enzyme deficient in Pompe disease? It is alpha glucosidase or acid maltase. And enzyme replacement therapy is available for this. So alpha glucosidase or acid maltase, and you have enzyme replacement therapy available for Pompe disease. So this we already discussed. So you have a pellagra like rash, Hartnup disease. What do you see here? Coarse facies. Coarse facies. You can see that there is puffiness around the eyes and thick lips are there, and so coarseness in the facies is there, and there is corneal opacity also. So all these, in both the pictures you see this coarse facies. So this is compatible with the diagnosis of Hurler syndrome, which is type 1 mucopolysaccharidosis. Okay. And what are these? So these are some skeletal changes which can be seen in mucopolysaccharidosis. Can you appreciate proximal tapering of the metacarpals? So they are called bullet shaped metacarpals. And you can see the beaking of the vertebral bodies, anterior beaking of the vertebral bodies. So all these are known as dysostosis multiplex. Dysostosis multiplex, which are again features of mucopolysaccharidosis. Okay, mucopolysaccharidosis. Okay, yes, in addition you can get J-shaped sella, you can get O-shaped ribs and so on. Okay, what do you see here? So the bone marrow biopsy of a child with pancytopenia and massive splenomegaly showed these cells, and there are some skeletal lytic lesions also. So this cell, so almost every other exam this question comes in some form or the other. So this is a, yes, very good. So this is Gaucher cell with the crumpled tissue paper appearance of the cytoplasm, and this is the Erlenmeyer flask deformity. So this is Gaucher disease, okay, Gaucher disease, which is due to deficiency of which enzyme? Glucocerebrosidase. So there is pancytopenia with massive splenomegaly, and you have enzyme replacement therapy available for this disorder. What do you see here? A 18-month-old child presented with reddish urine and these palpable red spots on both lower limbs. So you have palpable purpura. So you have these palpable purpura present mainly on the lower limbs along with kidney involvement in the form of hematuria. So what we are thinking here is the diagnosis becomes Henoch-Schönlein purpura. It is usually a self-limiting illness, but in severe cases we may use corticosteroids or immune modifying agents, right? Okay. Now what is the diagnosis in a child with fever for 8 days and the following features? So what do you see here? So you see bilateral non-purulent conjunctivitis, you see some rash involving the trunk, the edema and erythema of extremities, the adenopathy or lymphadenopathy, and there is mucosal involvement in the form of strawberry tongue. Okay, strawberry tongue. So all these are features in which favor the diagnosis of, yes, Kawasaki disease. So Kawasaki disease, you need fever for more than 5 days. So you need fever for, so here you have fever for 8 days. So fever for more than 5 days with any 4 out of 5 features. Conjunctivitis, which is bilateral non-purulent, rash, edema, erythema, adenopathy, mucosal involvement. So cream is the mnemonic. Conjunctivitis, rash, edema, erythema, adenopathy and mucosal involvement. Any 4 out of these 5 features along with fever for more than 5 days is Kawasaki disease. Treatment of choice for Kawasaki disease is, yes, it is IVIG, and along with that of course we give aspirin. So what is this important complication of Kawasaki disease? What do you see? This is a coronary angiogram. So this is showing coronary artery aneurysm. So in untreated Kawasaki disease, children can land up with this coronary artery aneurysm. Okay, right? Now, a 13-year-old girl who complained of fever and muscle pains, and there are these clinical features. You can see these rashes, violaceous rashes around the eyes, which are called heliotrope rash. Heliotrope rash, and on the knuckles and on the interphalangeal joints, you can see some papules. They are called the Gottron papules. So all these favor a diagnosis of, yes, what is the diagnosis here? Yes, so because it is in a child, so this is called juvenile dermatomyositis. So you've got case scenarios on this previously, I'm sure you'll be able to identify juvenile dermatomyositis, okay. So there is inflammation of muscles, it's a painful condition, Gauer's sign can be seen positive, muscle MRI can show you the affected muscles, okay. A neonate has these skin lesions, okay, these skin lesions, and was found to have a systolic murmur and deafness on evaluation. There is a history of fever with rash in the mother during the antenatal period. What is the probable diagnosis? Yes, so you have this systolic murmur and you have deafness. Okay, so you have a systolic murmur, there is deafness, so there is a congenital heart disease. Okay, congenital heart disease, and you have deafness, right? And you have this blueberry muffin lesions, the blueberry muffin lesions. Okay, so all these are compatible with a diagnosis of congenital rubella syndrome. Congenital rubella syndrome. Okay, the most common heart disease in congenital rubella syndrome is patent ductus arteriosus. Okay, patent ductus arteriosus, which can initially in the neonatal period, sometimes it can give a systolic murmur, later it becomes a continuous murmur. Okay. What is the diagnosis here? So a child with conjunctivitis, coryza, a wet kind of a look, and these erythematous maculopapular rash all over the body. So this is a typical case of, yes, waiting for your replies. So a child with conjunctivitis, with some coryza, with fever, with rash, these erythematous maculopapular rash, which is confluent at places. This is the typical rash that you see in measles. And the clinical feature which is pathognomonic is said to be Koplik spots, which are present on the mucosal surfaces. In the buccal mucosa, you can see erythematous areas with a bluish white center. Koplik spots can also be present on conjunctiva, vagina, so any mucosa they can be present. So for the management, it is mainly supportive, and vitamin A also is given in addition. Okay. Now, what is your diagnosis in a child with fever and this rash? So here you can see macules also, papules also, vesicles also, pustules also, and some crusting lesions also. So pleomorphic kind of a rash. Pleomorphic, that means different types of rashes in the same individual. So here our diagnosis becomes varicella infection or chicken pox, okay, right? What do you see here? A neonate has some skin lesions on the abdomen, some limb abnormalities. So some limb abnormalities is there. So skin lesions, some limb abnormalities, and you see microcephaly. So skin abnormalities, limb abnormalities, microcephaly, history of fever and rash in the mother during the antenatal period. So our most probable diagnosis here will be congenital varicella syndrome. So this microcephaly, this cicatrizing skin lesions, the limb defects, all these are in favor of congenital varicella syndrome. Okay. What do you see here? So you can see there is a, this rash in a child with fever, and it appears as if somebody has slapped the child. The cheeks are all red. Other parts are not so red. So this slapped cheek appearance of rash is seen in which condition? It is called erythema infectiosum. Yes. And what is the causative agent? Waiting for your answers. So it is erythema infectiosum, and the causative agent is parvovirus B19. Very good, Twinkle. So parvovirus B19, right? And what is the diagnosis in this child with low grade fever and vesicles on extremities and oral ulcers? You can see some vesicles on the extremities are there, on the palms also, oral ulcers, near the oral cavity also some blisters, low grade fever. So this is very common condition, and you have seen, small epidemics of this condition recently. Very good. So this is hand, foot, mouth disease. Okay, hand, foot, mouth disease, again a viral infection mainly by the enteroviruses, the Coxsackie virus. Okay, the hand, foot, mouth disease is self-limiting illness. Now, what is the diagnosis in this child with unilateral swelling in the cheek? You can see in the parotid region unilateral swelling. So it is usually associated with fever. It can be unilateral or bilateral. So this condition is known as mumps. Very good. So this is a condition known as mumps, and there can be orchitis or testicular involvement also, and a very important complication of this condition is aseptic meningitis. Okay. What do you see here? So you can see these notched incisors. It is known as Hutchinson's teeth. So this Hutchinson's teeth, and you will be telling me in which condition we see it. So this Hutchinson's teeth is a part of the Hutchinson's triad. So Hutchinson's triad obviously has got three things. So Hutchinson's triad has got three things. So Hutchinson's teeth, interstitial keratitis and sensory neural hearing loss. So many a times you have got question on this. Okay, sensory neural deafness. So Hutchinson's triad is one of the late manifestations of congenital syphilis. Okay, one of the late manifestations of congenital syphilis. Okay, right. Another abnormality of teeth that you can get in congenital syphilis are these mulberry molars. Can you see these molars have got so many cusps, small cusps, they appear just like mulberry. So mulberry molars is another teeth condition that you can see in this congenital syphilis. Okay, right. What is your diagnosis here? Can you see a grayish, adherent pseudo-membrane kind of thing in the throat of a child? So this child is an unimmunized child who presented with sore throat. An unimmunized child who presented with sore throat, fever may or may not be there, it is seen only in 50% cases. Okay, and this child has got an adherent greyish structure on examination of throat which is called a pseudo-membrane. So this is a condition which is called diphtheria. This pseudo-membrane is greyish white in color, leathery, and it is adherent. If you try to remove it, it can bleed, it can cause airway obstruction. It is made up of RBC, WBCs, fibrin, degraded, denuded epithelial cells, necrotic epithelial cells, and so on. Right? So here our diagnosis of course becomes diphtheria. So we take a throat swab, we take a swab and a part of the membrane very carefully. We can see it under the microscope after doing the Albert staining. And you can demonstrate the diphtheria. The bacilli. Okay, so you can see these metachromatic granules here, and the drug of choice for diphtheria is anti-diphtheritic serum. So apart from antibiotics, anti-diphtheritic serum is a must, and mortality and morbidity is very high in cases of diphtheria. The close contacts will require antibiotic prophylaxis using either penicillin or erythromycin or azithromycin, and immunization of contacts if they have not received any booster in the last 5 years or received less than 3 doses of diphtheria containing vaccine, immunization of contacts again is mandatory. Now 6-year-old, again an unimmunized patient who sustained a penetrating injury, dirty wound 10 days back, presents with trismus, rigid muscles of limbs, clear sensorium. What is your diagnosis? So the diagnosis is glaring at you. I think I need not tell the diagnosis. I'll be waiting for your answers. So you can see the trismus or the locked jaw. The child is not able to open the jaw. There's a spasm of the limbs. So here of course our diagnosis is tetanus. So you can see so many deadly diseases can be prevented by strict immunization of all the children, right? Now again here there is a newborn whose mother received no antenatal care, unbooked case, and the child had progressive difficulty in sucking and swallowing and incessant crying from day 7 of life. So, and the child has this stiffness. You can see this is opistotonic posturing, arching of back, extreme increase in tone. So this is opisthotonus or arching of back. So here our diagnosis, yes, what is your diagnosis here? So this is neonatal tetanus. The mother is unimmunized and this baby has got neonatal tetanus. It will manifest beyond day 3 of life. Okay. First 48 hours the child will usually be okay. What do you see here? So what do you see on this vaccine vial? You can see a circle and a square. What is it? Yes, who will tell me? Many a times you've got questions related to this. So what is this? So this is a, very good. So this is a VVM. And what is the full form of VVM? Yes. What is it? So it is called vaccine vial monitor, right? It has got an outside circle and an inner square. Okay, so the color of this outside in order for the, so it will show you whether the vaccine has sustained heat damage or not. If the color of the inner square is lighter than the outside circle, like here and here, you can use this vaccine vial. But if the square is same color as the circle or darker in color, you cannot use it. So you cannot use this vial, you cannot use this vial. Okay, right? So that is the vaccine vial monitor. Okay. Now coming to some important images from systemic pediatrics, the last part of our discussion for today. So what are these facial features in a child with anemia requiring multiple transfusions suggestive of? So what you can see here is there is depressed bridge of nose, there is frontal bossing. If the mouth would have been open, you would have seen prominent teeth, prominent malar, prominences. So this is hemolytic facies. Previously chipmunk facies was the term used. Nowadays we don't use that terminology. It is hemolytic facies seen in chronic hemolytic disorders like thalassemia. Chronic hemolytic disorders like thalassemia. And what do you get on X-ray in these individuals? You can see this hair on end or the crew cut appearance, increased thickness of the skull bone. So it is called hair on end or crew cut appearance. Okay, hair on end or crew cut appearance. Okay, increased thickness of the skull bones, again seen in chronic hemolytic disorders like thalassemia. Now, this question has come recently in the NEET PG exam. So, what is the diagnosis in the peripheral smear in this child with anemia? So, you can see here that there are some RBCs which have been elongated and some are crescentic in shape, right? Elongated and sickle shaped. So, this is sickle cell disease. So, the question asked you that in a child with such blood picture, if you know there is bone involvement, joint involvement, and what kind of organism will cause the infection. So, in a child with sickle cell disease, the most common cause of osteomyelitis would be salmonella. So, normally most common cause of osteomyelitis in children is Staph aureus. But in sickle cell disease, it is going to be salmonella, and there will be painful crisis, okay, painful different type of crisis in sickle cell disease you can see, and you have the HBS, which is formed due to a point mutation in the 6th position of the beta globin gene, okay, where the glutamate is replaced by valine, right, okay. Now, if there is sudden onset, these reddish spots like this in a 9-year-old child who is otherwise well. So, in a well child, if you get sudden these red spots, there is a history of viral upper respiratory tract infection 2 weeks ago. What is the possible diagnosis? So, these are petechiae, and you know the viral infection few days ago, otherwise well child, all these point towards a diagnosis of ITP or idiopathic or immune thrombocytopenic purpura, right. The first line treatment of ITP in children nowadays, as per the latest recommendations, is wait and watch. But in cases where there is severe thrombocytopenia or where the access to medical care is not proper, there is remote access, then you can use a short course steroids or IVIG. So, a short course of prednisolone or IVIG can be used for treatment of acute ITP in children. Okay, right? So, a 10-year-old child presented with a history of fever, bleeding gums, blood in urine and generalized fatigability for last 15 days. So 10 years old child hai, the child has got fever, bleeding gums, blood in urine, matlab bleeding ho rahi hai, fever hai, generalized fatigability, that means severe pallor is there, and sternal tenderness, hepatosplenomegaly. The bone marrow is showing abnormal increase in the blast cells comprising 50% of the marrow. So here of course our diagnosis becomes acute leukemia, okay. Our diagnosis becomes acute leukemia, okay, acute leukemia. I am not going to the details of the types of leukemia and all, that must be discussed in pathology. So, this is a typical case scenario where we are going to suspect a diagnosis of acute leukemia. And of course, ALL is more common in children as compared to AML. B-cell ALL is more common than T-cell ALL in children. Now, in which disease the following cells are seen on lymph node biopsy? So, there is a child who has got fever and enlarged cervical and axillary lymph nodes, big lymph nodes and fever. And on biopsy of lymph node, you get these cells which are the Reed-Sternberg cells. So, what is your diagnosis then? So, your diagnosis, Reed-Sternberg cells, your diagnosis becomes Hodgkin disease, okay. And the treatment of Hodgkin disease, we use the ABVD regime, okay. So, we use adriamycin, so we use bleomycin, vincristine and doxorubicin. So, ABVD regime is what is used for treatment. Now, in a child where a 2.5-year-old child with fever, seborrhea and generalized maculopapular rash, and you see these punched out lesions, and mind you, it is a child, so it is not multiple myeloma, okay. So, punched out lesions on the skull with fever, seborrhea, 2.5-year-old child, maculopapular rash, your diagnosis is not multiple myeloma, it is Langerhans cell histiocytosis, okay. Langerhans cell histiocytosis, the drugs used in treatment are like vinblastine, prednisolone and so on, okay. What are these? So, skin biopsy in the same child we were talking about can show this on electron microscopy. So, these are called Burbeck granules. Again, Burbeck granules are tennis racket shaped structures which are again seen in LCH, okay, Langerhans cell histiocytosis. Now, a child with VSD, what kind of heart disease is it? Is it a cyanotic or acyanotic heart disease? So, we know it is a acyanotic heart disease. But if a child with VSD has developed cyanosis and clubbing, you can see cyanosis and clubbing. Cyanosis and clubbing in a child with VSD, what will be your diagnosis? Yes. What will be your diagnosis in a child with VSD with cyanosis and clubbing? Then your diagnosis becomes Eisenmenger syndrome, where there is reversal of shunt due to irreversible pulmonary vascular obstructive changes. So, Eisenmenger syndrome is our diagnosis here. So, if VSD was not there, if you would have got just cyanosis and clubbing in a child, we will think of cyanotic heart diseases like tetralogy of Fallot, okay, if VSD was not mentioned as such, okay. Now, what do you see here? So, this is a condition where the child has hypertension and the X-ray has revealed these notching of the inferior margin of ribs. Notching of inferior margin of ribs, it is seen as in a condition, yes. Who can tell me the answer? Notching of inferior margin of ribs. It is in a child with hypertension. What will you suspect? So, we will suspect the diagnosis of, very good, Tariq, Debantika, yes. Sanghita, Prakhar, so coarctation of aorta or narrowing of aorta. Okay, you can also get a figure of 3 sign in coarctation of aorta. What do you see here? So, of course, I have drawn it for you. So, it's a boot-shaped heart. So, you can of course appreciate the boot-shaped heart. And so, what is your diagnosis here? So, it is a boot-shaped heart. It is also called core and sabot appearance. Okay, and the diagnosis here of course becomes tetralogy of Fallot. Okay, tetralogy of Fallot, and there is also pulmonary oligemia. That means you cannot see the bronchovascular margins very prominently. What do you see here? So, here you see the egg on side appearance. So, egg on side appearance is seen in which heart disease? Yes, waiting for your answers. So, it is seen in, come on, egg on side appearance, which heart disease? So, very good, Priya, Tulsi, Tariq, Mohammedul Hassan, SS. So, it is seen in TGA or transposition of great arteries. Okay. Where do you see this snowman or figure of 8 appearance? Snowman or figure of 8 appearance, which congenital heart disease? Snowman or figure of 8 appearance, which congenital heart disease? So, it is supracardiac type of, yes, it is supracardiac type of, come on, supracardiac type of, yes, Tariq, Bhupesh, Nasreena, Sanhita, Mash, Priya. So, supracardiac type of TAPVC, total anomalous pulmonary venous connection, right? What do you see here? So, I have already drawn it for you. So, it is a box-shaped heart. And in which condition do you see a box-shaped heart? Which congenital heart disease? There is huge cardiomegaly. It is known as box-shaped heart. So, it is called Epstein anomaly. Okay, where there is the abnormal tricuspid valve, there is atrialization of the right ventricle, Epstein anomaly. And you get such huge P waves. Can you appreciate these P waves are so big? These P waves are so big, they are looking like Himalayan peaks. So, you get Himalayan P waves. In which condition? So, Himalayan P waves in ECG, again Epstein anomaly. And yes, maternal lithium use. So, during pregnancy, if a mother is on lithium, there are more chances of Epstein anomaly in the baby, right? Atrialization of the ventricle. What do you see here? A newborn is born with respiratory distress, frothy secretions from the mouth, not able to feed properly. You inserted a nasogastric tube, and you can see that the nasogastric tube did not go into the stomach. It got coiled up in the upper part only. So, your diagnosis here becomes, yes, your diagnosis here becomes, so it is esophageal atresia with tracheoesophageal fistula. Esophageal atresia, that means there is no communication between the esophagus and the stomach. So, esophagus is ending blindly. Esophagus atresia with tracheoesophageal fistula. That is your diagnosis here. You can see that there is gas in the stomach, and you can see that the nasogastric tube has not gone beyond the upper esophageal pouch. Okay. Now, a child who has got failure to thrive, short stature, recurrent episodes of diarrhea, abdominal distension, and you did upper GI endoscopy and duodenal biopsy, it showed the following. What is your diagnosis? And the antibodies which are implicated here is anti-TTG IgA. Antibodies are elevated. So, you can see that there is villus atrophy, there is crypt hyperplasia and increase in intraepithelial lymphocytes. So all these are features of celiac disease where there is sensitivity to gluten. And you've got questions related to treatment also. The treatment of choice for celiac disease is lifelong gluten-free diet. Okay, lifelong gluten-free diet. Okay, right. What do you see here? So in a child, infant who presented with recurrent episodes of constipation, so there has been constipation, fever, and you did a barium enema, and you can see that there is a narrowing. So there is this narrowed zone of the bowel. You can see this narrowed zone of the bowel, okay, and there is abrupt transition zone and the proximal dilated bowel. So this is typically what you get in, yes. So it is Hirschsprung disease, which can have an important complication called toxic megacolon. So this is Hirschsprung disease. You can do a rectal biopsy to confirm the diagnosis. You can do the acetylcholinesterase staining. You can see the hypertrophy nerve bundles. Okay. What do you see here? In a child, an infant who presented with recurrent episodes of crying, red currant jelly stools and an abdominal mass. So that is a typical triad, and you did a barium enema. You can see the typical claw sign. So this is a claw sign, and with the typical case scenario that I mentioned, the diagnosis here becomes very good. Gaurav, Muhammadul, Kia, Karthika. So of course, sorry I cannot name all of you, but so many of you answering, it is really, really heartening. Yes, it is intersusception, where there is telescoping of the bowel into the adjacent segment. You get many other signs here, radiological signs, coiled spring sign. Okay, so a lot of signs in intersusception, and the typical case scenario, incessant crying, red currant jelly stools and abdominal mass. Okay, what do you see here? So you see a single bubble appearance. So single bubble appearance on the X-ray, and you get a infant who has got repeated episodes of projectile non-bilious vomiting. Projectile non-bilious vomiting, okay. So we can think of congenital hypertrophic pyloric stenosis. Congenital hypertrophic pyloric stenosis. Okay, congenital hypertrophic pyloric stenosis. And you can get the electrolyte abnormality here, that is the metabolic alkalosis, okay, with paradoxical aciduria. So hypochloremic metabolic alkalosis, because the HCl from the stomach is coming out in the vomiting. So congenital hypertrophic pyloric stenosis. Questions also come from the ultrasound findings in this condition, the pyloric length, the thickness, the antral nipple sign. I am sure you've covered in radiology. Okay. So congenital hypertrophic pyloric stenosis, you get a single bubble appearance and you get a double bubble appearance. So double bubble appearance in duodenal atresia. So duodenal atresia, double bubble appearance. Okay, double bubble appearance. So one bubble is because of the enlarged stomach and another is because of the duodenum. Okay, double bubble appearance. Now what is this congenital lung malformation? You can see that the left upper lobe has overinflated and has hyperinflated, has come to the right side also, right? And you have the mediastinal shift. So this is a congenital lung malformation where an infant presented with respiratory distress. What will you think of? So this is congenital lobar emphysema. Okay, congenital lobar emphysema. So if you are getting a newborn or a infant with respiratory distress soon after birth, the X-ray is showing hyperinflated, especially the left upper lobe is the most common to be involved. It is congenital lobar emphysema. Okay. Now this is another congenital lung malformation. These are all potential questions which can come. So here you can see again cystic shadows in the thorax. But you can see that the diaphragm boundary is intact. The diaphragm margin is intact. So this is not congenital diaphragmatic hernia, though it is similar looking to that. So this is a condition which is called CCAM, congenital cystic adenomatoid malformation. The new name for this is CPAM, congenital pulmonary airway malformation. Okay. So you can get these congenital lung malformations also. Now, a 2-week-old baby presents with noisy breathing that improves when the baby is made to lie in prone position. And laryngoscopy shows this picture. So you can see this is a omega-shaped epiglottis. You can see the omega-shaped epiglottis, and there is a stridor which improves in prone position in an infant. Typically, we get it in laryngomalacia. Very good, guys. So laryngomalacia is the answer here. And it is usually a self-limiting condition. It will improve as the baby grows. Now, what is your diagnosis in this child with high-grade fever? sore throat, and tender cervical lymphadenopathy. So this you can see the tonsils are enlarged, there are palatal petechiae, so this is acute pharyngitis or acute pharyngotonsillitis. Okay, you can call it acute pharyngitis or acute pharyngotonsillitis. Palatal petechiae are there. If there is high grade fever, if there are pus points, exudates, we will think of a streptococcal illness. Otherwise, viruses can also cause a similar picture. So this is acute pharyngitis. So if you are suspecting streptococcal pharyngitis, you can do a throat swab culture or a rapid antigen detection test. Antibiotics should be started as soon as possible within 9 days of onset of illness to prevent acute rheumatic fever. Okay, right? Now, what is this diagnosis in this child with high grade fever, drooling of saliva and stridor? So, this is the child who has got high grade fever, drooling of saliva and stridor. You see the airway by laryngoscopy, you can see all inflamed. You can see the epiglottis is all red in color, inflamed. Cherry red epiglottis is what you see here. Cherry red epiglottis, and you can contrast it with the normal airway. So this is the normal airway and this you see is the cherry red epiglottis. In the sick looking toxic child, our diagnosis of course is acute epiglottitis. The most common organism responsible is streptococcus in immunized children. Okay. What do you see here? So you see a thumb sign. So in children with acute epiglottitis, you can see on the lateral X-ray thumb sign, the inflamed epiglottis. Okay. What do you see here? A child presented with low grade fever, noisy breathing. X-ray of the neck showed this picture. So you can see that the neck X-ray is showing that the airway has narrowed and has become like the steeple of a church. So airway is narrowed just like the steeple of a church. So this question has come very recently in the NEET PG 2023 exam, and this is the steeple sign. Steeple sign which is seen in acute laryngotracheobronchitis or croup, right? And this is a viral illness, the most common causative organism being parainfluenza virus. So what is the treatment of choice for a child with croup? Remember, there is no role of antibiotics as such. The treatment of choice is single dose dexamethasone. And in moderate to severe cases, you can give nebulized epinephrine as well. So single dose dexamethasone is the treatment of choice, right? The drug of choice. So treatment related questions also come from croup. So single dose dexamethasone is the treatment of choice. In moderate to severe cases, you can add on nebulized epinephrine. No role of antibiotics as such unless you are suspecting a secondary bacterial infection. Okay. Now this child had recurrent episodes of fever and cough, and on examination there is clubbing also, and the CT is showing these, these cystic areas. So this is a child with bronchiectasis or suppurative lung disease, where you can have this fever, cough, clubbing. So this bronchiectasis can be secondary to tuberculosis, can be secondary to cystic fibrosis or any other underlying lung condition. You can see these cystic air spaces, right? And clubbing is there. Now, if you get a case scenario like this, where you have unilateral lung findings, a typical age group, the toddler age group, and the child has choking while eating peanuts, his chest X-ray is showing a unilateral hyperinflated lung. If you auscultate, you will get unilateral lung findings, wheeze, decreased air entry. So, unilateral hyperinflated lung, you will think of foreign body aspiration. Okay, foreign body aspiration, and the child needs urgent bronchoscopy and removal of the foreign body. Okay. What procedure is being done here? So this is a baby who presented with decreased urine output, and the baby was having altered sensorium, lethargy. So this procedure is being done. So what procedure? Come on, who can tell me what procedure is being done here? So again, these are some new things which I've included which can be potential questions for you. So this procedure is known as, yes. So this is being done in the abdomen. You can see in the just below the umbilicus. So a stiff catheter has been introduced, and through this catheter we are introducing the fluid and taking it out. Very good, Prakash. So this is peritoneal dialysis. This is a form of renal replacement therapy. Peritoneal dialysis that is being done in a child with acute kidney injury or renal shutdown or acute renal failure. Okay. Now, a 3-year-old child. A 3-year-old child presented with sudden onset of decreased urine output, generalized edema, petechial spots over the body. So, decreased urine output, generalized edema means acute kidney injury. Some renal shutdown is happening, renal injury, renal dysfunction. Petechial spots may be due to thrombocytopenia. And the peripheral blood picture, it is showing some broken RBCs or cystocytes. You can see some broken RBCs, some helmet cells and all. So, broken RBCs or cystocytes. So, what is your diagnosis here? Come on, waiting. So, yes, I can see Deepak Gupta has already written the diagnosis, Pratiksha, Ravi Prakash, Gaurav, MSH, okay. So, you have this renal, so acute kidney injury, microangiopathic hemolytic anemia, whereby you see cystocytes, and petechia are because of the thrombocytopenia. So, all these features are diagnostic of hemolytic uremic syndrome or HUS. It can be secondary to diarrhea, dysentery, or it can be D minus HUS, which is due to problems in the alternate complement pathway. Okay. So, now again during the antenatal period, a 30-year-old lady was found to have oligohydramnios. So, there was a stillborn baby with some abnormalities. You can see this high forehead is there, you can see that there is flat kind of facial profile, you have wrinkled hand like washerwoman hand. So, all these are suggestive of very good Sanghita, Tariq, Debantika, Prakhar and Deepak. So, Potter's sequence or Potter's facies. So, here it is there severe renal dysfunction, there is oligohydramnios, there is pulmonary hypoplasia and a flat facial profile, washerwoman's hand and feet. Okay. What is this renal malformation? It is quite common in Turner syndrome. This is quite common in Turner syndrome, this malformation where both the kidneys have fused, the lower poles of both kidneys have fused in the midline. It is called, yes, Megha, very good. So, this is horseshoe kidney. Okay, horseshoe kidney. You can see the kidney is resembling a horseshoe. Okay. Now, what does this radionuclide cystogram show in a 2-year-old child with recurrent urinary tract infection? So, recurrent urinary tract infection is there. You can see that this area is the bladder. Okay. And the radionucleotide isotope has been introduced from the urethra to the bladder, and you can see it is going to the ureters as well. So, it is showing vesicoureteric reflux. It is showing bilateral vesicoureteric reflux. Yes. So, it can appear like a flower base. Yes. So, it is a vesicoureteric reflux that you see here. Okay. In the radionuclide scan with recurrent UTI. And here what you see? So, here again you have done a dye study. You have done this you have introduced a dye from the urethra, from the ureter, and you're looking at both the ureters. You can see a retrograde flow has been seen from the bladder to the ureters, and the ureters are dilated and tortuous, the calyces are dilated. So, again this is bilateral vesicoureteric reflux, and there is of course hydronephrosis also. So, there is bilateral vesicoureteric reflux and hydronephrosis. So, there is reflux nephropathy, one of the very important structural causes of recurrent urinary tract infection in children. Okay. So, bilateral vesicoureteric reflux almost grade 4 to grade 5 is there, severe, and there is hydronephrosis also. The ureters are also dilated. Okay. What do you see here? So, there is this infant who has straining while micturition, and the mother is telling that the urinary stream is not appropriate. You did a micturating cystourethrogram, you introduced a dye from the urethra into the bladder, and you can see that the bladder is distended and the posterior urethra is also dilated. So, this is the keyhole sign that you see here, and your diagnosis becomes the posterior urethral valve. Okay. So, it is posterior urethral valve. It is the most common cause of lower urinary tract obstruction in males. You can do fulguration of the valves through a urethroscopy. Okay. So, vesicoscopy and urethroscopy, and you can do endoscopic ablation of the valves. So, posterior urethral valves is the diagnosis here. Okay. What do you see here? So, you can see the anterior abdominal wall, the anterior wall of the urinary bladder, everything is absent, and the bladder mucosa is exposed to outside. This is the umbilical cord stump. Okay. And you can see that the bladder mucosa is exposed to outside. Okay, bladder mucosa is exposed to outside. So, this condition is called, yes. So, very good. This has been asked previously in one of the exams recently. So, it is bladder extrophy, also known as ectopia vesicae. So, bladder extrophy. Okay. Now, this is a child who presented with prolonged neonatal jaundice, constipation, and you can see there is abdominal distension, there is umbilical hernia, there is protruded tongue, this myxedematous or puffy looking faces, right. So, all these features are suggestive of the diagnosis of congenital hypothyroidism. So, ideally newborn screening should be done for congenital hypothyroidism. Okay. right, using, so you can either do an umbilical cord blood sample or a heel prick sample beyond 48 hours of life. So congenital hypothyroidism, the most common cause is thyroid dysgenesis, but if the child has goiter, the most common cause would be thyroid dyshormonogenesis. Okay, so this is congenital hypothyroidism. Now if a baby is born with such a genitalia and the baby has got dehydration, salt wasting, shock, okay, you will think of, yes, so this is basically a baby with ambiguous genitalia. You are not able to make out whether it is a male or a female. Okay, so you can see a phallus and you can see the labioscrotal folds, but difficult to make out whether it is a male or a female. So ambiguous genitalia with salt wasting, dehydration, shock, we think of congenital adrenal hyperplasia, which is most commonly due to which enzyme deficiency? 21 hydroxylase deficiency. It can be due to other enzyme, other adrenal enzyme deficiencies also, but the most common is 21 hydroxylase deficiency. And for the treatment, we use hydrocortisone and fludrocortisone. Okay. Now, this is a child with obesity. And you have been given a history that there are retinal pigmentary changes, some vision problems also, and you can see that there is post-axial polydactyly in all the limbs. So this is a typical condition, a syndrome, yes. So this is not Prader-Willi syndrome. Prader-Willi syndrome does not have polydactyly. Prader-Willi syndrome will have obesity, hypogonadism, feeding difficulties in the infantile period, developmental delay, hypotonia and so on. Yes, who can answer? Very good, Deepak Gupta. So this is Lawrence Moon Bardet-Biedl syndrome. Okay, Bardet-Biedl syndrome. So you have obesity, polydactyly, retinal pigmentary changes and so on. Okay. So coming to the neurological deficits, so there are neural tube defects, there is spina bifida occulta where nothing can be seen from outside, there is a meningocele where transillumination will be positive because it is just a sac of meninges containing the clear CSF, no neural components, okay. And you have the myelomeningocele where you have neural component also, so transillumination will not be positive. So what is this? So here you can see a sac of meninges with some neural component in it. Most commonly it is seen in the lumbosacral region. So how do you differentiate? So Shania, in spina bifida occulta, you will see from outside there will be nothing or there could be some sacral dimple or a tuft of hair. In meningocele, there will be a clear sac, a red colored sac, reddish looking sac, clear sac with clear fluid and it will be very soft. And if you put a torch, it will glow. Transillumination will be positive in meningocele. While a myelomeningocele will look something like this. So it is a swelling in the lower back, usually lumbosacral region with some neural component, solid component inside it. So this is the myelomeningocele. I hope it is clear now. How do you distinguish? Right? So myelomeningocele. Okay. So it is most commonly seen in the lumbosacral region. Now if it comes out from the cranial bone, so then it becomes an encephalocele. So this is an occipital encephalocele. So it is a swelling, a sac of meninges with some neural component coming from the lower part of the skull. It is called an encephalocele, which can be a potential question. Now this CNS abnormality has come multiple times in various questions. This is a condition where you are not going to resuscitate the baby if this condition is present. So the scalp, cranial bones, everything is absent and the brain is exposed to outside. So this condition is known as, yes, it is called anencephaly. Very good, Kartika, Shrini, Romisha, Tulsi, Tasmina, Yasmin. So this condition is called anencephaly, which is due to the failure of closure of the anterior neuropore. Okay, anencephaly. What is this congenital abnormality? So here the upper part of the brain and the upper part of the spine is exposed to outside. The infant's neck is hyperextended in a stargazing position. The neck is absent. So it is called, yes, this is a slightly difficult condition called INI-encephaly. So here there is a defect of the inion or the lower part of the posterior aspect of the occiput. Okay, INI-encephaly. A similar condition where the almost entire spine is defective and exposed to outside, it is known as, it is a very severe condition, has been asked in FMGE July 23, this exact picture. It is called, yes, I will wait for your answers, it is called, so this is a condition where almost the entire spine is exposed to outside, a very severe neural tube defect. Yes, it is craniorachis. Very good, all of you. So craniorachis. Okay. Right. So moving ahead, so this is a child with a large head. You can see venous prominence is present. You can see the sun setting sign. So what is your diagnosis here? So large head, sun setting sign, bulging anterior fontanelle, large anterior fontanelle. So there is a hydrocephalus in this child, which can be due to various causes. Okay, hydrocephalus. And the treatment of choice for hydrocephalus in children, what surgery is the treatment of choice? Surgery of choice is VP shunt or ventriculoperitoneal shunt. That has also been asked previously. And yes, McEwan's sign is positive, a crackpot kind of a sound you hear on percussion of the skull. The sunset sign of the eyes, you can see the eyes are like as if looking downwards, sunset sign is there. What do you see here? So this is a neuroimaging, a CT scan showing grossly dilated ventricles. So again, you can see the hydrocephalus, the grossly dilated ventricles here. Okay. What do you see here? So this is a contrast enhanced CT scan where you see a prominent, blood vessel here. So that is called the vein of Galen malformation. So in this condition, again, hydrocephalus can be there and the child presents with a high output cardiac failure, and there is a bulging anterior fontanelle, and if you put a stethoscope on the anterior fontanelle, you can hear a cranial bruit. So this is the vein of Galen malformation, okay. So which can be seen in newborn babies, in infants, right? A cranial bruit is found on auscultation, right? What do you see in this condition? So here you can see herniation of the cerebellar tonsil through the foramen magnum. What condition is this? So this is called the herniation of the cerebellar tonsil through the foramen magnum. So yes, this is called the Arnold-Chiari malformation. Okay, Arnold-Chiari malformation. It can be associated with myelomeningocele as well. What do you see here? So this is a dilated fourth ventricle. So this is a non-communicating hydrocephalus, dilated fourth ventricle. So this condition, yes, waiting for your answers. So this condition, this malformation, come on. So this is called, very good Kartika. So this is the Dandy-Walker malformation. Dandy-Walker malformation. So one of the causes of non-communicating hydrocephalus. What do you see here? So both the cerebral hemispheres are absent. The entire skull appears to be empty almost, and transillumination is positive. So you can see this glow is called transillumination. Even in meningocele, if you put a torchlight, you will see a glow like this. So this condition where if you put a torchlight and you can see a glow here, and if you do a CT scan, you see both the cerebral hemispheres are absent and only fluid-filled sacs are present. So this condition is called, very good Rumisha and Shalupriya, Chetna, it is hydranencephaly. Hydranencephaly, okay. What do you see here? So here you can see a single eye is there, a tubular nose called proboscis, right? So that is seen when a child has got holoprosencephaly, where abnormal fusion of the brain of both sides is there, both the eyes are also fused, the nose becomes tubular, it is called proboscis. So this is a condition which is seen usually in holoprosencephaly. Okay, this can be seen in infant of diabetic mother, or otherwise also this cranial malformation can be seen. You can see that you cannot differentiate between the two cerebral hemispheres, they are fused in the midline. Both the ventricles are also fused in the midline. So this is holoprosencephaly, abnormal fusion of the cerebral hemispheres of both the sides. Okay, right, holoprosencephaly. What is this abnormality in a child with seizures? So this is a MRI, sagittal view. Can you notice any abnormality? This child has presented with recurrent seizures. Who can tell me? So can you see any abnormality here? Yes, come on, waiting for your reply. So what is this? Yes, holoprosencephaly as such is a defect of the forebrain. So here what you see in this condition, this child has got seizures, and what can you notice? Very good Sanghita. So you can see normally in the sagittal view there should have been a corpus callosum here, which is absent. So this is agenesis of corpus callosum. Agenesis of corpus callosum. This can be present as such, or it can be a component of Aicardi syndrome. Okay, agenesis of corpus callosum, you get developmental delay, you get recurrent seizures and so on. Now, what is this neurocutaneous syndrome? So, this is the port wine stain. Somebody was referring to the port wine stain. So, this is the port wine stain involving one half of the face. So, it can involve one half of the face, the distribution of the trigeminal nerve. If you do a cranial imaging, a CNS imaging, you will find a tram tract calcification. So, this is a neurocutaneous syndrome known as Sturge-Weber syndrome, and these children can present with seizures. So, Sturge-Weber syndrome, right? Port wine stain of one half of the face. What is this neurocutaneous syndrome? So last few slides to go. So it's been a long session, but I've tried to exhaustively cover, a lot of important images that we can expect in the upcoming exams. So this is what is this? So this is a café au lait spot, a hyperpigmented macule, a café au lait spot. And you can see what are these? What are these? So these are Lish nodules. So café au lait spots and Lish nodules, you see it in, very good, you see it in neurofibromatosis type 1, which has got autosomal dominant inheritance. You can see axillary freckling also, family history will be positive, neurofibromas can be there. Now, which neurocutaneous syndrome has got intellectual disability and seizures and features like this, adenoma sebaceum, and you can get these hypopigmented macules, which are called ash leaf spots or ash leaf macules. Yes, very good guys. So this is tuberous sclerosis. In tuberous sclerosis, one more skin lesion that you commonly get is, so this is what you get. So skin lesion which has got an orange peel kind of appearance. So it is called shagreen patch. Shagreen patch again seen in tuberous sclerosis which has an orange peel like appearance. Okay. Now, a child presented to you with difficulty in getting up from sitting position, okay, a boy, and there is a history of similar illness in his maternal uncle, in his mama, in his maternal uncle, and you can see that there is a pseudo hypertrophy of the calf muscles. So, I can see Tariq, Kartika, Chetna, Pratiksha, Priya, Akriti, Megha, Shalupriya, Jyoti. So this is Duchenne muscular dystrophy. And if the child is presenting at a later age, if it is less severe form of disease, then it will be Becker muscular dystrophy. So you see the pseudo hypertrophy of the calf muscles, the dystrophin gene is involved, one of the largest genes, right? So usually there is deletion and a lot of mutations can be possible. It is a big gene. So Gowers sign will be positive, and one more sign that will be positive in these is Valley sign. So you can see a depression between the hypertrophic deltoid and the infraspinatus muscles. So Valley sign can be positive again in Duchenne or Becker muscular dystrophy, and you get this Gowers sign. That means the child has difficulty in getting up from sitting position. So from a sitting position, if you ask the child to get up, the child will take the support of his own hands and slowly get up. That is called Gowers sign. But it is a very non-specific sign, can be seen in any cause of proximal muscle weakness. Okay, Gowers sign, usually seen beyond 3 years of age. Okay. And what is this? This child has got some bony abnormalities like frontal bossing. Okay, frontal bossing is there, prominence of the frontal region, frontal and parietal bossing. There is pectus carinatum or prominent chest. And it is not very evident in this picture, but there is prominence of the costochondral junctions or rachitic rosary. What else do you see? There is wrist widening. You can see the wide wrist. There is a pot belly kind of a thing. There is bending of bones. So all these features are suggestive of rickets. And rickets is most commonly due to vitamin D deficiency. Okay, right? Nutritional rickets, and you can sometimes get this depression along the attachment of diaphragm in rickets, that is called Harrison's sulcus. So whenever the child is breathing, you can see a sulcus that is forming in the chest, Harrison's sulcus, right? And you can also get this, this question came in one of the exams recently in the NEET PG 2023. So you can get these bow legs or you can get knock knees. So all these are features of rickets that you can get. And it is most commonly due to vitamin D deficiency, though other causes can also be there. Now what do you get in an X-ray in a child with rickets? So in general there will be decreased density of the bones, and there are 3 terminologies. So there is cupping, fraying and splaying of ends of long bones. Okay, cupping, fraying and splaying of ends of long bones. Cupping means this concavity you can see, that is cupping. Fraying means the irregularity that you can see, that is fraying. And splaying means the widening of the ends of long bones, that is called splaying. So these are the changes that you get in a child with rickets on X-ray. Now what is the diagnosis in this child with gum bleeding? Okay, so this child has got gum bleeding and painful lower limbs, and you can see again prominence of the costochondral junction. It is called scorbutic rosary, which is painful, tender, angular. So scorbutic rosary is there. You can see the gum swelling and bleeding, and you can see the swelling of the limbs. So there is subperiosteal hemorrhage involving the long bones. So here of course our diagnosis is scurvy due to the vitamin C deficiency. So we know vitamin C is required for collagen synthesis. Collagen is the backbone of blood vessels. So if collagen synthesis is not happening properly in vitamin C, the blood vessels are all fragile. They'll be bleeding everywhere. So there's gum bleeding, subperiosteal bleeding involving the lower limbs. That is very, very painful. Now, because there is such a painful condition of lower limb, the child will not want to move the lower limb. So we call it, it will appear as if the child has paralysis, but child actually has pain, so the child is not moving the limb. So it is called painful pseudo paralysis of lower limbs. Painful pseudo paralysis of limbs. Okay, in scurvy. And the treatment, of course, is vitamin C. So in an X-ray in a child with scurvy, what you can get? So you can get, so in a child with scurvy, you can get ring-shaped epiphysis, okay. So you get this ring-shaped epiphysis or Wimberger's sign, and you can get this subperiosteal hemorrhage. So this is the subperiosteal hemorrhage. Subperiosteal hemorrhage, the Wimberger's sign or the ring-shaped epiphysis, okay. You get the white line of Frenkel, white line of Frenkel, the Trummerfeld zone, the black area which is here, the pencil thin outline of the cortex. So, lot of findings you can get in X-ray in a child with scurvy, okay. And what do you see here? So, last 2-3 slides to go. So, what do you see here? So, you can see it. Can you appreciate here the bones appear more white than usual? So, there is this more white bones than usual, increased density of the bone, looks like marble bone disease, and you can also see a bone within bone appearance, okay. So, can you appreciate that it appears as if there is a small femur inside the big femur. Here also it appears as if there is a small femur inside this big femur. So, bone within bone appearance and increased density of bones. So, this is typically what you see in, yes, what is your diagnosis? Very good. So, this is osteopetrosis or marble bone disease, where you have the bone within bone appearance and increased density of the bones, right? So, the child can present with hepatosplenomegaly, pancytopenia and so on. What do you see here? So, these are pictures of antenatal ultrasound, okay, where you can see the fetus and you can see that the limbs of the fetus are showing fractures. So, multiple fractures if you are seeing in utero, in a fetus, what will you think of? So, the bones of the fetus must be so fragile that in utero, in a protected environment also it is fracturing. What will you think of? What will come to your mind? So, if fracture is happening so commonly in a baby, that means the bones are really brittle. So, brittle bone disease, or what is known as, very good Megha and Dibankika, Prakhar, Gaurav, Ravi Prakash, yes. So, we will think of osteogenesis imperfecta, and this question has come in the NEET PG exam last year. So, osteogenesis imperfecta, where the bones are very fragile, okay, right, and you have recurrent fractures. So, in osteogenesis imperfecta, you can also get this blue sclera when the baby is born. Blue sclera will be there. Because of the recurrent fractures, there will be these bony deformities and there can be deafness as well. So, all these are features of osteogenesis imperfecta, which is due to defect in the type 1 collagen, and you know it has multiple forms are there, but most of them have got a autosomal dominant inheritance. And in the treatment of this condition, bisphosphonates have a role. They decrease the risk of fractures. Bisphosphonates like pamidronate, alendronate, they have a role in decreasing the risk of fractures, okay. So, moving on to our last slide for the day. So, what is this condition where you can see that the proximal segments of limbs are all very short and the limbs of this child are appearing like the flippers of a seal? Yes, so this condition is called, very good Sangeeta, Chetna, so it is called phocomelia, right, phocomelia. And this is due to, if you know, mother takes thalidomide, maternal intake of thalidomide during pregnancy can lead to this condition which is called phocomelia, where the limbs are very small, the proximal segment, and the limbs appear like the flippers of a seal. So, I believe we've covered lots and lots of important images from pediatrics and related topics, right? So, I'm sure this revision, if you see it once or twice again, it is going to be very helpful for all your upcoming exams, whether it be NEET PG or FMGE or any other exam that you're aiming for after your MBBS, right? But remember, nothing will work unless you do. And I'm sure each and every one of you is working to your level best. Like we are also trying to, work as much as possible for you to accumulate all the images, all the study materials, to provide a quick, crisp revision for you of all the important topics. And I'm sure all of you are right on the track. And it shows your dedication and determination that on a Saturday afternoon also you're sitting and watching this video till the very end. So I'm sure all of you are going to do very, very well. Just a few more weeks to go, right? And see you on the other side. All the very best. God bless you. Keep revising, keep working hard, and if we really work hard, nothing can stop us from achieving what we want to, right? So thank you so much. I hope all of you have enjoyed this session, and do share your feedback with me. All the very best for your upcoming exams. God bless you. Thank you so much. Have a nice day.